Hey all of you, I'm Dr. Sakshi Arora Hans, your Obs and Gynae faculty, and I will be taking up a recall session of Obs and Gynae questions from NEET PG 2021. Now, in NEET PG exam, there were 21 to 22 questions in Obs and Gynae, in which 16 questions, they were directly from Obs and Gynae, right? So 8 from Obs and 8 from Gynae. But there were 5 questions which were integrated questions. So there was integration between pathology and OBGY, integration between pharmacology and OBGY, and integration between pediatrics and OBGY. So there were these around 5 questions which were an overlap between these subjects. They were integrated questions, and as expected, this year's NEET PG, it did reflect how the next exam is going to be, wherein the questions were at the very outset, it seemed that the paper was very easy, but actually paper was tricky. You had to know the real concept behind the question, and not only that, you had to know the niche details of that particular topic in order to be able to answer the question, because the options given were very closely similar. There were questions where you could rule out 2 and you were confused between 2. And as I always say, this confusion is solved only and only if you study a subject in detail and you build concepts in that particular subject. So was your Obs and Gynae paper. Now, in Obs and Gynae, as I was telling you, there were 5 questions which were an overlap, which were integrations between OBGY and various other subjects, in which pharmacology and OBGY had 3 questions which were integrated questions. One question was on ACE inhibitors, the other question was on endomethacin use in pregnancy, and the third question was on anticoagulants in pregnancy. Then there was one question which was an overlap between pathology and OBGY, so it was an integration between path and OBGY, wherein there was a question on dysplasias, metaplasias, and carcinoma and their histopathological findings. Then there was one question which was an integration between pediatrics and OBGY, wherein they had asked you a question on fetal circulation. So yes, integrated questions were present this year in NEET PG 2021. Now, if we talk about the individual, the individual topics from where the questions had come, so in obstetrics, you got 2 questions from general obs, where one question was on obstetrical score and the other question was related to dating of pregnancy. There were 3 questions which had come from early pregnancy bleeding or early pregnancy losses, in which one question was on recurrent abortion, one on ectopic pregnancy, and one on gestational trophoblastic neoplasias. Then there was a question on postpartum hemorrhage, there was a question on infections in pregnancy, and there was one question on malpresentation, on occipito-posterior malposition rather. Then when we talk about gynae, surprisingly, there were 4 questions which had come from congenital malformations. So in gynae, yes, 4 questions had come from congenital malformations in NEET PG 2021. There was one question on amenorrhea, which was a very easy question on amenorrhea, but in INI-CT, there were 4 questions on amenorrhea. Then there was one question on prolapse, one question on fibroid, one question on vaginitis, and just one question on contraception. So this year, the focus was on, having various topics rather than concentrating on contraception. And surprisingly, there wasn't any question on gynae cancers, which came as a big surprise, because all of us, we focus a lot on gynae cancers when mostly questions are asked from gynae cancers. But this time, there wasn't any question from gynae cancer. There wasn't any question from a partogram, and there was just one image-based question in gynae, and that too from congenital malformation, and that too a very, very easy question. So yes, the Obs and Gynae was easy, but it was tricky, I would say. So let's begin with our discussion on the questions. Number 1 question, a preemie at term presents with labor pain and multiple painful vesicles on her vulva. no rashes were found on other parts of her body, what will be your management? Now, I know all of you know answers to these questions, so I will not just be discussing answers. I will also be taking up important points related to that topic. And what you are seeing over here, the screenshots, these screenshots are the places where I have taught these topics and these questions in particularly in the video. And the timeline is also given there, right? So over here, this patient has come to you with multiple painful vesicles on her vulva. There are no rashes on other part of her body, and patient is in labor pain. So if there are multiple painful vesicles on vulva and there are no rashes in other part of the body, vesicles means that we are dealing with a case of herpes genitalis, and this is how it appears. Multiple painful vesicles are present on vulva. Now, etiology of herpes genitalis is most commonly it is caused by HSV2 and then by HSV1. That is the second most common cause. The incubation period is 3 to 12 days, and the primary lesion in case of herpes genitalis is vesicles, and these vesicles, they are going to rupture and ultimately ulcers will be formed. So there will be multiple grouped tender ulcers which will be present on the vulva ultimately, and ultimately what happens is that the boundaries of all these ulcers, they will merge and they will fuse with each other, and that is how they form polycyclic erosions, right? Apart from this, your question can also mention that there is bilaterally enlarged inguinal lymph nodes and tenderness will be present. But please remember, bubo formation doesn't happen in case of herpes genitalis, right? The diagnosis of herpes genitalis, what you have to do is you have to take fluid from the vesicles and you have to send it for PCR or for culture. And simultaneously, you are also going to do a T-Zank smear. In a T-Zank smear, you take the fluid from the vesicles and you stain it with Giemsa stain. When you stain it with Giemsa stain, you get multinucleated giant cells and acantholytic cells, right? So this is what you are taught in dermatology as well. Treatment of herpes genitalis infection. I'm not talking about, how the mode of delivery just now. I'm just now talking about how do you treat herpes genitalis infection. Treatment is you have to give tablet acyclovir 400 mg thrice a day for 7 days. And this is done not only in non-pregnant females, but in pregnancy also the drug of choice is acyclovir. Now, what is the mode of delivery? Please remember, if patient has active genital herpes infection and patient is in labor, then the mode of delivery is cesarean section, right? So if patient is not in labor, I'm going to do an elective cesarean section. If patient is in labor, I'm going to go for an emergency cesarean section. But cesarean section has to be done whether the patient is in labor or she's not in labor if active genital herpes infection is present, right? Now, this herpes genitalis infection, it is vertically transmitted, and the maximum time for vertical transmission is at the time of labor. Right, so maximum transmission happens at the time of labor. This is a screenshot from Up to Date where I want you to read a little bit about this vertical transmission, because you may get questions in future about vertical transmission of herpes genitalis infection as well. Right? So over here, I'm highlighting the important points for you. Most mothers of the newborns with perinatally acquired HSV infection, they lack a history of clinically evident genital herpes. So if a newborn in baby is having a perinatally acquired HSV infection, it is not necessary that the mother is having symptoms. It could be that patient is asymptomatic and still the transmission has happened. The highest risk of neonatal infection occurs in women with primary genital herpes simplex infection acquired near the time of delivery. So near the time of delivery, if mother gets HSV infection, then the chances of baby having HSV is maximum. Viral shedding can occur in absence of maternal symptoms and lesions, right? The frequency of viral shedding is higher in HSV2 versus HSV1, although the type of genital HSV affecting the risk of neonatal transmission and the neonatal sequelae, clinical management of pregnancy is not influenced by HSV. So that means that although the viral shedding is more in HSV2 than HSV1, but the chances of baby acquiring HSV and the clinical sequelae, all that is independent of the type of HSV. right? Now, suppose if there is in utero infection which is acquired transplacentally or transcervically across the membranes, right? So this is not happening at the time of labor, but it is happening transplacentally or transcervically during pregnancy. Then HSV, primary HSV infection can result in miscarriages. It can result in congenital anomalies, and these congenital anomalies are ventriculomegaly and other CNS anomalies. It can result in preterm labor and IUGR. So if HSV infection is happening and it is happening during pregnancy but not near term, right? So it is not near term we are talking about, it is happening at any time of pregnancy, then HSV at that time can also be vertically transmitted, and at that time a primary HSV infection can result in abortions, it can result in congenital anomalies, specifically the congenital anomalies of central nervous system, preterm labor and IUGR. But what you have to remember is this is seen only if HSV is primary infection, right? In case of recurrent infection, these things are not seen. Right? So recurrent HSV is not associated with all these findings, right? Similarly, what you have to remember is that use of invasive fetal monitoring and preterm birth. These are two things which increase the risk of neonatal infection in patients with viral shedding. So at the time of labor, suppose active genital herpes infection is not present. So if active genital herpes infection is not present, I'm not going to go for a cesarean section. I'm doing a vaginal delivery. But at that time also, the chances will be high if you do invasive, the chances of fetus acquiring or the neonate acquiring HSV would be high if you go for instrumental delivery or, if you go for artificial rupture of membranes, if you go for invasive fetal scalp monitoring. So whenever you are doing vaginal delivery in a genital herpes infection, see, in genital herpes infection, if active genital herpes infection is present, that is an indication for cesarean section. But if active genital herpes infection is not present and you are doing vaginal delivery, at that time also you have to remember that you don't have to do artificial rupture of membranes. You don't have to use fetal scalp monitoring, fetal scalp electrodes, and preterm labor also increases the chances of viral shedding and the baby getting the infection, right? Now, what are the important points which you have to remember when you are giving acyclovir treatment to a pregnant female? So here I want to discuss two cases with you. Suppose there is a pregnant female with HSV infection and this HSV is a primary infection which is happening any time in pregnancy. And as I told you that in order to treat herpes simplex infection, you have to give tablet acyclovir. So to this pregnant female, I'm going to give tablet acyclovir 400 mg 3 times a day for 7 to 10 days. And then I'm going to restart treatment at 36 weeks. So at that time, I gave the treatment for 7 to 10 days. And then at 36 weeks, I'm going to restart the treatment, right? As I told you that there may be cases where patient is not having clinically evident genital herpes infection, but still viral shedding is happening, right? So over here, in all patients who have primary HSV infection, at the time of infection, you treat the infection for 7 to 10 days and then you restart their treatment with acyclovir at 36 weeks of pregnancy and you continue it until delivery, and this is what is called as the suppressive therapy. Case 2 is, suppose there is a pregnant female who has recurrent herpes infection. Now, if a pregnant female has recurrent herpes infection at any time during pregnancy, you may or you may not give acyclovir treatment at that time. But it is mandatory for you to give suppressive therapy. That means it is mandatory for you to give acyclovir therapy starting from 36 weeks and up till delivery, right? And then in the next slide, I have told you what I told you just now, that the route of delivery, mandatory cesarean section has to be done if active genital herpes infection is present, that you know. And number 2, if prodromal symptoms are present. So if active genital herpes is not present, but prodromal symptoms are present, for example, if vulval pain or burning is present, then also you have to do a cesarean section. The other thing is, suppose these two are absent. If these two are absent and you are going for vaginal delivery, then you have to remember that ARM should be avoided, instrumental delivery should be avoided, and fetal scalp pH monitoring should be avoided. right? So this is all what you have to remember about HSV infection during pregnancy. Just one or two more points is that suppose there is active genital herpes infection and patient has preterm labor. So in that case, you are going to manage preterm labor like you manage at that particular gestational age, right? So that management of preterm labor is going to be the same. The only difference is that you have to give antivirals, right? Because herpes genital infection, it is present on labia and vulva. It never enters into the uterus. So it's not going to enter into the uterus. So you are going to treat the patient like you treat for preterm labor. But yes, along with that, you are going to give her antivirals. And when we talk about breastfeeding, breastfeeding is normally not contraindicated in HSV infection. Breastfeeding is contraindicated only if active lesions are present on breast. So if active lesions are present on breast, then breastfeeding is contraindicated. Clear to all of you, right? Coming to question number 2, a 26-year-old pregnant woman on examination was found to have infra-umbilical flattening and FHS was heard over the lateral side. What could be the fetal presentation or position? And this we've just discussed in the videos. And I have shown you these two images in the videos. Now in image A, what you can see is that the occiput is facing posteriorly. So image A is showing occipito-posterior position. And image B, the occiput is facing anteriorly, so it is showing occipito-anterior position. Now, when you compare these two images, what you are seeing in these two images is that in occipito-posterior position, there is infra-umbilical flattening, whereas the flattening is not there in occipito-anterior position, number 1. Number 2, what I am seeing is that the back is towards the flank, right, in occipito-posterior position, whereas in occipito-anterior position, the back is towards the midline. And all of you know that fetal heart sounds are best heard over the back. So in case of occipito-posterior position, because back is towards the flank, so FHS would be heard towards the flank. Whereas in occipito-anterior position, because back is towards the midline, so the FHS is going to be heard towards the midline. Right? Number 3, if you look at the fetal limbs in occipito-posterior position are more towards the midline, whereas fetal limbs in occipito-anterior position are more towards the flank, right? And now I want all of you to compare the position of the anterior shoulder in both these images. So compare the position of anterior shoulder. See, over here, this is the anterior shoulder of the baby, and over here, this is the anterior shoulder of the baby. So in case of occipito-posterior position, so the anterior shoulder is little away from midline. It is little away from the umbilicus. Whereas in case of occipito-anterior position, the anterior shoulder is towards the umbilicus. So these are the differences between occipito-anterior and occipito-posterior position when you do a per abdominal examination. Right? Now, in the question which was given to you, it was said that there is infra-umbilical flattening and fetal heart sound is heard over the lateral side. That means fetal heart sounds are heard over the flank region. So what is it? Is it bro? Is it anterior? Is it occipito-posterior? Or is it right dorso-anterior? It has to be occipito-posterior position. So this is a pretty easy question. The other thing which I want you to know is if they ask you what is the most common cause of occipito-posterior position, the most common cause of occipito-posterior position is an android pelvis. The second most common cause is deflexed head. Next important thing which I want to tell you is, please remember that all malpresentations are more common in multigravida female. But occipito-posterior position is more common in a primigravida female. If they ask you occipito-posterior position is most common in which pelvis, so just now I told you it's most common in android pelvis. But suppose if a prefix is added in front of occipito-posterior. For example, if they ask you persistent occipito-posterior position, right? So, or a direct occipito-posterior position. So, before occipito-posterior, a prefix is added. So, whenever a prefix is added, suppose they are asking you a persistent occipito-posterior position or a direct occipito-posterior position is more common in which pelvis, then your answer becomes anthropoid pelvis. Clear? Okay. Then comes question number 3. Again, question number 3 is one of the questions which was, I would say an easy question, but you had to apply your concept. I have taught this question to you in the videos. We have seen how the score is calculated. I don't think so after watching the video, you should have any, confusion regarding this question. But there are students who have confusion, so I'm going to talk to you about this in detail along with references. But this question was covered in your video, and if you did your, if you watched your videos correctly and if you applied the concept correctly, you are definitely going to mark this answer correct, right? So this is a woman who had undergone dilatation and curettage for molar pregnancy 6 months ago, presents with persistent symptoms of abdominal pain and distension. On further investigation, she had persistently elevated beta HCG and cannonball foci were seen on chest X-ray. What is the appropriate management? So a patient in whom beta HCG is persistently raised, after H-mole evacuation, it indicates that now molar pregnancy has, transformed into gestational trophoblastic neoplasia. Now, the most common gestational trophoblastic neoplasia, which is going to happen after molar evacuation, is an invasive mole. But over here, your question is saying that cannonball foci are present on chest X-ray. So that means they are telling you directly that this patient of molar pregnancy after evacuation, now she has developed choriocarcinoma. Right? So this is a case of choriocarcinoma, and till here, none of you had any problems. All of you came to the diagnosis that yes, this patient has developed choriocarcinoma. Right? Now, in choriocarcinoma, there are 2 ways in which you have to stage choriocarcinoma. There is a way of staging and there is a way of risk assessment of choriocarcinoma. The staging for choriocarcinoma is the FIGO staging. Right? And in FIGO staging, stage 1 means the disease is confined to the uterus and beta HCG levels are high. Stage 2 means that now it has spread to pelvic organs, like it has spread to adnexa or to vagina. Stage 3 means that choriocarcinoma has spread to the lungs with or without genital tract involvement. And stage 4 means other metastasis has happened. Right? So definitely this patient, because she has cannonball foci on chest X-ray, so this means metastasis has occurred on lungs. And please remember that on lung metastasis, when you do a chest X-ray, the most common appearance which you get is a cannonball appearance. The most common is not a snowstorm appearance. Second most common appearance is a snowstorm appearance, right? So till here it's clear that this is stage 3 choriocarcinoma, right? Now comes that for management or for risk assessment of choriocarcinoma, you have to do a WHO prognostic scoring system. Now, WHO prognostic scoring system, it divides choriocarcinoma into 2 categories, into low-risk choriocarcinoma and high-risk choriocarcinoma. The difference between them is that in low-risk choriocarcinoma, I'm going to treat with a single drug, that is only methotrexate, and in high-risk choriocarcinoma, I'm going to do a multi-drug therapy, that is EMACO. Right? Now, this is something which I have taught you in class as well, that stage 1 of choriocarcinoma, this stage 1 of choriocarcinoma where the disease is confined to the uterus, right? These are primarily low-risk choriocarcinomas. So if it is a stage 1 choriocarcinoma, even without WHO prognostic scoring system, I can say that the disease will belong to stage 1. It will be a low-risk choriocarcinoma and I can safely give them single drug therapy. As far as stage 4 is concerned, most of the stage 4 will be high-risk choriocarcinomas where you will have to give multi-drug therapy. The problem comes, or the confusion comes, in stage 2 and stage 3. In stage 2 and stage 3, whether am I going to give them a single drug therapy or whether am I going to give them a multi-drug therapy, and that is where a WHO prognostic scoring system comes into play. Now, only in stages 2 and stage 3 the confusion arises, and that is why the role of WHO prognostic system is basically for stages 2 and stages 3, right? Now, in stage 2 and stage 3, what am I going to do is, I'm going to do a WHO prognostic scoring system, and if score comes less than equal to 6, I'm going to say it's a low risk and I'm going to treat them with a single dose therapy. right? That is single drug therapy, not a single dose. That's my mistake. Please do not remember that. Remember a single drug therapy, not a single dose therapy. And then if it is more than equal to 7, if the score is more than equal to 7, that means it's a high risk and I have to treat them with combination therapy, that is EMACO. And a simplified way of this scoring system, I've already taught you in the videos. But over here, I want you to look at this table. Right? So this is WHO's scoring system. Now, in WHO scoring system, if age of the patient at which the gestational trophoblastic neoplasia, that is choriocarcinoma, is happening, if age is less than 40, you give a score of 0. Right? And in our question, the age was given as a 26-year-old female. So as per her age, I'm giving her a score of 0. Then it was given that the antecedent pregnancy was a molar pregnancy. Now, if antecedent pregnancy is a molar pregnancy, again you give a score of 0. Then it was given that the antecedent pregnancy was 6 months back. So if the antecedent pregnancy, if the interval between the diagnosis of choriocarcinoma and the antecedent pregnancy is 4 to 6 months, you give a score of 1. So for 6 months, I'm giving a score of 1. Then the last point is where the metastasis has occurred. Over here, the metastasis has happened in lungs. And as you can see, if metastasis happens in lungs, which is the most common site for metastasis, again a score of 0 is given. So as per our question, this patient belongs to stage 3. This patient belongs to stage 3 and her WHO score is coming as 1. Right? And because the WHO score is coming as 1, I am going to give her methotrexate only. Right? I am not going to give her EMACO. I am not going to do hysterectomy. Now, when we look at methotrexate, there were 2 options in methotrexate. One was methotrexate with folinic acid and one was simply methotrexate. Right? So please remember that in case of choriocarcinoma, when you are giving methotrexate, you give a multi-dose therapy where you are going to give methotrexate on day 1, day 3, day 5 and day 7. And on alternate days, you are going to give folinic acid. So you have to give methotrexate in multiple doses and on alternate days, you have to give folinic acid. That is the answer to this question. Right? So over here, answer has to be methotrexate with folinic acid. Clear to all of you? Okay. Coming to question number 4. Question number 4 is on ectopic pregnancy, where the question says a 30-year-old female who was on treatment for infertility with 6 weeks of amenorrhea came with abdominal pain and mild vaginal bleeding. Her beta-HCG levels are 2800 international units and on ultrasound, a left adnexal mass of 3 centimeters is seen. Right? A gestational sac with no cardiac activity is seen in the adnexa. What is the most appropriate treatment for this patient? So this question is made really easy for you because they are saying that a gestational sac is seen in the adnexa. If a gestational sac is seen in the adnexa, that means it's a case of ectopic pregnancy. Right? And this ectopic pregnancy presently is unruptured ectopic pregnancy. Now, in unruptured ectopic pregnancy, what is the management which I'm going to do? In unruptured ectopic pregnancy, I have 3 kinds of managements. Number 1, I can go for expectant management. Number 2, I can go for medical management. And number 3, I can go for surgical management, that is laparoscopic management. Right? So, milking of tube anyway is not the answer. Now, when it comes to the best management, please remember I have told you in the videos also. So this question again, you would have done correctly if you would have watched the videos, properly and you would have noted each and every point which I tell you during the videos. In the video, I have told you that the best management for unruptured ectopic pregnancy is medical management always, right? So medical management is the best management, and for medical management, the drug which you use is methotrexate. In contrast to choriocarcinoma, the methotrexate which you give in ectopic pregnancy is given as a single dose. Right? So please remember, for management of choriocarcinoma, you were giving multi-dose therapy, multi-dose methotrexate with folinic acid. But for management of ectopic pregnancy, you give single dose of methotrexate. Right? And there are certain requirements which have to be, fulfilled before you give methotrexate, amongst which the absolute requirements are mother should be stable. That means vitals of the patient should be stable. In other words, it should be a tubal unruptured ectopic pregnancy. Right? The relative indications or the relative requirements which should be fulfilled are the size of the ectopic should be less than 3.5 centimeters, HCG value should be less than 5,000 international units per liter, and there shouldn't be any cardiac activity. Right? So over here, because the size of the ectopic pregnancy is 3 centimeters and beta HCG is 2,800 international units, and it is a case of unruptured ectopic pregnancy, so all the requirements are being fulfilled. So I'm going to go for medical management. Whenever all requirements for medical management are fulfilled in unruptured ectopic pregnancy, you have to choose medical management as the answer. You are not going to choose expectant or laparoscopic management as the answer. Right? Now, when do you do expectant management? See, expectant management, please remember that it has to be done in case of resolving ectopic pregnancy. And how do I come to know that it's a resolving ectopic pregnancy? Because beta HCG values should be consistently decreasing. So whenever they want you to answer, that's a simple trick which I'm giving you, that whenever they want you to answer, the answer to be given as expectant management, they will always give you a hint that beta HCG done on day 1 was this much and on day 2 was this much. And you will see that the beta HCG value on day 2, the second reading, will be much less than the first reading. Right? So if they want you to answer it as expectant management, they will always give you 2 readings of beta HCG in which the second value will be less than the first value. Then the size of the ectopic pregnancy should be less than 3.5 centimeters and, beta HCG should be less than 1,000 international units per liter. Best results for expectant management are seen when beta HCG values are less than 200. Now, so in this case, there isn't any doubt that I'm going to go for medical management. I'm going to use methotrexate, and it will be a single dose methotrexate. Now, some of you tend to get confused because in your books it is written that you give methotrexate on day 1, and you simultaneously measure the beta HCG levels, then you measure the beta HCG levels on day 4, and then you measure the beta HCG levels on day 7. Right? And if the decrease on day 7 as compared to day 4 is less than 15% of the value which you got on day 4, then you repeat the entire cycle. Yes, you repeat the entire cycle here. That is not what is called as multi-dose methotrexate. Multi-dose methotrexate means the entire dose of methotrexate is being divided and given on alternate days. Over here, the entire dose in ectopic pregnancy, the entire calculated dose, right, which is 50 milligrams per meter square, is going to be given on day 1. And if this cycle fails, then I'm going to repeat the entire dose will be given again on day 1 of the next cycle, right? So that is a single dose methotrexate therapy which you give in ectopic pregnancy, although you may give it up till 3 cycles. That's a different story altogether, right? So 3 cycles can be given for methotrexate, and on these 3 cycles, you have to measure beta HCG on day 4 and day 7 of every cycle. Right? And even after 3 cycles of, medical management, if ectopic pregnancy is not resolving, in other words, beta HCG values are not coming down, then that is unsuccessful medical management, and that is an indication for doing surgical management. Right? Okay. Coming to the next question. Next question is, a 30-year-old woman on OCPs for the past 6 months presents with amenorrhea for past 6 weeks. What would be the best method of assessing the gestational age of the fetus in this patient? So this patient, maybe a urine pregnancy test has come out to be positive. This patient was on oral contraceptive pills for the past 6 months, and now for past 6 weeks, she's come to you with amenorrhea and she's pregnant. Now they want to know what is the best method for assessing the gestational age. See, for assessing the gestational age, we use the Naegele's formula. Right? And all of you know that how do you calculate the expected date of delivery from Naegele's formula? So to the LMP, you have to add 9 months and 7 days, or you have to add 280 days. But generally, the easiest method is you add 9 months and 7 days to get the expected date of delivery. But please remember that this measurement, this EDD which you get, or by this method when you calculate the gestational age, there are two requirements which have to be fulfilled. Number one, the female's menstrual cycles should be regular. So prior to conception, her cycles should be regular. Then only I'm going to apply Naegeli's rule, number one. Number two, there shouldn't be any history of oral contraception prior to her conception, right? Because when you are using oral contraception, there are chances of delayed ovulation, and so your calculations, are not that accurate. That is why we confirm from the patient that her, she shouldn't have been using oral contraceptives prior to her conception. Now, in this case, there is history of using oral contraceptives prior to conception. Right? So in this case, I'm not going to use Naegeli's rule. I'm not going to add 9 months and 7 days, or I'm not going to add 280 days in order to know the gestational age. Simply, I'm going to do an ultrasound. That is a dating ultrasound. And on dating ultrasound, you know that the best ultrasound and the best parameter which can tell me the gestational age is ultrasound or TVS, which is done as early in pregnancy, and the best parameter is crown rump length, right? So over here, adding 280 days to the LMP, no. Fundus examination, again, that's not the best method of knowing the gestational age. Adding 256 to the days to the last menstrual period, no. Crown rump length by ultrasound, yes. So if patient has prior history of using oral contraceptive pills, then you have to in order to know accurately the gestational age, you should always rely on ultrasound, right? And again, this question you would have easily answered if you would have understood the concept of Naegeli's formula and the concept of dating scan, which we have done in our videos. Then comes next question, which is again a very, very easy question. A 28-year-old pregnant woman came for routine antenatal checkup in her second trimester. She has history of delivering 2 healthy full-term twins 4 years back. What is her obstetric score? So over here, obstetric score is represented by a single number of gravida and a single number of parity. And what is gravida? Gravida is the number of times a female has conceived. Present pregnancy has to be included in gravida. And please remember, twins or triplets, they are counted as single when you are counting gravida, right? So it is arising from a single conception. So they are always counted as one in calculating gravida. Similarly, what is parity? Parity is the number of pregnancies which have gone beyond the period of viability. Please remember, present pregnancy is not counted in parity, right? So parity is always the number of previous pregnancies which have gone beyond the period of viability. And again, in parity, twins and triplets is counted as a single conception. It's counted as a single parity, right? So in gravida and parity, the major difference is that gravida is the number of times a female has conceived, and it includes present pregnancy also. But parity doesn't include present pregnancy, and it is the number of previous pregnancies which have gone beyond the period of viability. So in this case, this patient is pregnant and she had, so this is her second pregnancy. Her first pregnancy was twin pregnancy, right? So how many times has she conceived? She has conceived twice. Parity is the number of previous pregnancies which have gone beyond the period of viability. So she had delivered 2 healthy full-term twins, and twins is taken as a single parity. So it is G2P1, right? This is one thing which you have to remember. In parity, present pregnancy is not calculated, right? Now these days, we use the GT-PAL system for giving the obstetrical score, and in GT-PAL system, G stands for gravida, and gravida, I have told you what it is. T stands for number of term pregnancies, and number of term pregnancies means pregnancies which have gone beyond 37 weeks, right? So then P stands for preterm pregnancies. Preterm pregnancies means any pregnancy which is, ending between 21 weeks to 36 weeks plus 6 days. A stands for abortions, all pregnancies which end at less than 20 weeks. And that includes your ectopic pregnancy. That includes molar pregnancy. So any pregnancy which is ending at less than 20 weeks they come under abortion. And L stands for living children at present, right? So this is the only place where twins and triplets will be counted. Twins will be counted as 2 and triplets will be counted as 3. But other than that, at every other place, twins and triplets, if they all will be counted as single, right? So suppose if I ask you, what is the GT-PAL system for this question? So over here, when we talk about the GT-PAL system, gravida will remain 2 only. Right now, parity, you have to represent it by T-PAL. So number of term pregnancies is 1. Right? Then number of preterms is 0. Number of abortions is 0. Number of living children, 2. So twins will be counted as 2 living children at present. Right? So this is the complete obstetrical score as per the GT-PAL system. Clear to all of you? Yes? Okay. Now, yes, this one is a little tricky one. This question is saying that there is a 30-year-old G4P3 and she had a first pregnancy loss at 8 weeks, second at 11 weeks with no cardiac activity, and third preterm delivery due to early onset preeclampsia. And what is the diagnosis? So you are having one loss at 8 weeks, the other at 11 weeks, and then there is a preterm delivery, and that preterm delivery is happening due to early onset preeclampsia, right? So now torch infections, this cannot be, because torch infections, they never present with recurrent abortions. This is not the kind of history which you're going to get in gestational diabetes mellitus, right? So this either is a case of syphilis or it's a case of APLA. Now, the diagnosis of APLA is made by a modified Sapporo's criteria, which is also called as the Sidney criteria. And we've done this in detail in our videos, wherein you should have one clinical criteria and one lab criteria should be fulfilled. Then we say that it is APLA syndrome. Right? Now, in lab criteria, you have either there has to be history of arterial or venous thrombosis, number 1. Or number 2, there have to be pregnancy complications. And what pregnancy complications? Number 1, if there is history of, second trimester abortion or more than equal to 10 weeks of abortion with morphologically normal fetus. Right? Number 1, history of one such abortion which is happening at more than equal to 10 weeks. Number 2, history of 3 abortions which are happening at less than 10 weeks when other causes have been ruled out. And number 3 is if there is history of 1 or more preterm birth, and this preterm birth should be happening either due to eclampsia or severe preeclampsia or due to placental insufficiency. Right? So out of these 4 things, number 1, arterial venous thrombosis, number 2, more than equal to 10 weeks of one pregnancy loss of more than equal to 10 weeks with morphologically normal fetus, or 3 or more pregnancy losses at less than 10 weeks, or one preterm delivery. Out of these 4 criteria, any one should be fulfilled, and the lab criteria are that there should be presence of anticardiolipin antibodies, or there should be, presence of lupus anticoagulant, or there should be presence of anti-beta-2 glycoprotein antibody on 2 occasions 12 weeks apart. Any of these antibodies which are present on 2 occasions 12 weeks apart, that becomes your lab criteria, right? So in this question, what I am getting is that this patient has had 2 pregnancy losses, one at 8 weeks, one at 11 weeks, and there is preterm labor, right? So 11 weeks, 1, that is also fulfilling a criteria, and 1 preterm labor due to preeclampsia, that is also fulfilling a clinical criteria. But yes, the question doesn't mention anything about the lab criteria. Right? Now, as far as syphilis is concerned, in syphilis, you remember I told you that syphilis follows the Kazovitz law. And what does Kazovitz law state? Kazovitz law state that in syphilis, as the period of gestation will increase, the period of, as the number of losses is going to increase, the period of gestation at which the loss is going to happen will also increase, right? So the outcome becomes better in syphilis with the number of pregnancies, right? So suppose there is a female who has 1 pregnancy lost and she is a patient of syphilis, she has syphilis. So At one time, pregnancy loss is going to happen at 8 weeks. Next time, when she is going to have her miscarriage, it will happen in the 5th month. Right? Then there will be a preterm delivery, then stillbirth, then a low birth weight baby, and then a normal child. This is what is Kazowitz's law. This is how pregnancy outcomes are seen in syphilis. That as the number of pregnancies increase, the outcome becomes better. Right? So this is from NCBI library, and again I have a screenshot for you from Up to Date, which says that in syphilis, you have the D.D. Kazowitz's law, which says if a woman with untreated syphilis has a series of pregnancies, the likelihood of infection of the fetus in later pregnancies becomes less. Thus, in successive pregnancies, she may have miscarriage at 5th month, next occasion stillbirth at 6th month, then birth of an infant with congenital syphilis who dies within few weeks, followed by birth of 2 to 3 infants with congenital syphilis who survive, and finally 1 or more healthy child may be born. Right? So in the videos also I told you, if they ask you that can syphilis lead to recurrent pregnancy loss? Yes, it can lead to recurrent pregnancy loss. But can syphilis lead to early recurrent pregnancy loss? No. Right? Now, in this question, what you are getting is that one pregnancy loss is happening at 8 weeks and second at 11 weeks. And that means both the pregnancy losses are happening in the first trimester. This is something which you are not going to get in syphilis. In syphilis, if one pregnancy loss is happening in first trimester, then the second is going to happen in the 4th month or in the 5th month, right? And then there will be a preterm labor, and that preterm labor will not be due to preeclampsia. Are you understanding that? So over here, one thing that 2 pregnancy losses happening in first trimester, that is making the diagnosis of syphilis unlikely. And number 2, preterm labor which is happening and they are saying it is due to preeclampsia. Right? That is again making syphilis an unlikely diagnosis, although both these are very close. You know, syphilis and APLA both can be answers to this question, but a better bet is APLA because over here they are saying that the preterm labor is happening due to preeclampsia, and they are saying that one pregnancy loss happened at 8 weeks and the second pregnancy loss happened at 11 weeks, and that is what is the clinical criteria for your APLA syndrome. So I would have marked this answer as APLA. If you have marked the answer as syphilis, I will not say that you did not think this question. You have, what you've read is right, but you just need to remember the concept which I told you in the video, that syphilis does not lead to early recurrent pregnancy loss. Right? So Kazowitz's law is seen, but you will never get pregnancy loss both in first trimesters, 8 weeks and 11 weeks. Clear to all of you? Yes? Question number 8. A pregnant woman at 36 weeks of gestation who has prosthetic valve replacement for mitral stenosis is on warfarin for her INR found to be 3. What is the appropriate next step in the management of this case? So again, this we've discussed so many times in the video. Now, in the videos, I have told you that at 36 weeks of pregnancy, you have to shift a patient who is on bioprosthetic valve, who is on, warfarin. You have to shift her to heparin, and I've told you that you have to shift on low molecular weight heparin. Now, why I am going to tell you this question in detail is because at so many other platforms, the confusion is between low molecular weight heparin and high V heparin. So let me clear all these confusions for you and let me teach you this in a little detail. And what I am telling you is from the 2020 American Heart Association guidelines or American College of Cardiology guidelines, right? So let's talk about females with prosthetic valve replacement. Now, females with prosthetic valve replacement, now there can be 2 types of valve replacements. Either they can be a bioprosthetic valve replacement or they can be a mechanical valve replacement. Now, in females who have undergone bioprosthetic valve replacement, there is no need for anticoagulants during pregnancy. All you need to do for them during pregnancy is you have to give them aspirin, low dose of aspirin throughout pregnancy, right? Now, but if mechanical prosthetic valves have been put, then yes, you have to go for anticoagulation, and that anticoagulation has to be given throughout pregnancy, right? Now, all of you know that there are basically two kinds of anticoagulants which are available. One is warfarin and the other is heparin. And in heparin, we have the option of low molecular weight heparin and we have the option of unfractionated heparin. The problem with both of them is that warfarin, although it's a very strong anticoagulant, and strong anticoagulant is needed in pregnancy because pregnancy is a hypercoagulable state, but warfarin can cross the placenta and it can lead to chondrodysplasia in the fetus, right? So, warfarin should be avoided in first trimester of pregnancy. So, if there is a bioprosthetic mechanical valve in the first trimester of pregnancy, I am going to give heparin. And always in pregnancy, the best heparin to give is low molecular weight heparin. Low molecular weight heparin, it can be given subcutaneously, whereas unfractionated heparin, it has to be given IV. So, I am going to give her low molecular weight heparin, which is given subcutaneously. Right? Some people also recommend, so American Heart Association has the new recommendations say that if the dose of warfarin, which is needed for anticoagulation in a pregnant female, is less than 5 milligrams per day, then you may use warfarin also in the first trimester. But the preferred one will always remain low molecular weight heparin. Right? Now, once the period of maximum teratogenicity is over, that means first 12 weeks of pregnancy are over, then from 12 weeks to up till 36 weeks, I'm going to switch over the patient to a stronger anticoagulant, and that is warfarin. Right? So, heparin, although it does not cross the placenta, but the problem with heparin is that heparin is a weak anticoagulant, and in pregnancy, I need a stronger anticoagulant. So from 12 weeks onwards and up till 36 weeks, I'm going to put my patient on warfarin. Now at 36 weeks, again, I'm going to put the patient on heparin. Now what heparin? That is the main thing. The heparin which I'm going to give will be subcutaneous heparin, that is low molecular weight subcutaneous heparin, because when you are giving subcutaneous low molecular weight heparin, you don't need to admit the patient. Unfractionated heparin, you will have to give IV. Right? So you will have to admit the patient. So at this particular moment at 36 weeks, I'm going to put the patient on low molecular weight heparin. And then 1 week before delivery, 1 week before her EDD, or at least 36 hours before her EDD. Now this is something which has been added new by American Heart Association guidelines of 2020, and they say that 1 week before delivery or at least 36 hours before her EDD, you are going to switch from low molecular weight heparin to IV unfractionated heparin. Now, why is this switching over being done? That is because of two reasons. Number one, that a low molecular weight heparin, it has got a longer T-half. And so, if a patient is on low molecular weight heparin and she goes into labor, then the chances of PPH are more in comparison to unfractionated heparin, right? And number two is protamine sulfate, which is, all of you know, is an antagonist for heparin. This protamine sulfate acts better on unfractionated heparin in comparison to low molecular weight heparin. It acts on both of them, but its efficacy is more in case of unfractionated heparin. So if we compare, it is 100%, if the efficacy is 100% for fractionated heparin, it is only 30 to 40% for low molecular weight heparin. So 1 week before her EDD or 36 hours before her EDD, I am going to shift the patient from low molecular weight heparin to IV unfractionated heparin. And then I'm going to stop all anticoagulants on the day of her delivery, and I'm going to restart anticoagulation 6 hours after vaginal delivery or 24 hours after cesarean section. I can start either with low molecular weight heparin or I can start with unfractionated heparin, and then gradually I can put them on warfarin, right? So this is what is the entire summary of what American Heart Association guidelines have said. I have given these guidelines over here. And if any of you want to read these guidelines, you can pause this video and you can read these guidelines. These guidelines are telling you what all I have told you in that particular table, right? So, Now, just one thing which I want you to see over here. As I told you, in pregnancy, low molecular weight heparin is preferred to unfractionated heparin, and the reference again I'm giving you over here. I want you to read. Where low molecular weight heparin is unavailable or cost prohibitive, or if anti-10A levels cannot be monitored, right, then continuous infusion of unfractionated heparin can be used as an alternative. But in pregnancy, generally what we are going to prefer, we prefer using low molecular weight heparin. Right? The other thing is, you have been taught this in your medicine, you have been taught this in pharmacology, but I am just reinforcing it again here, that when you are using warfarin as an anticoagulant, you have to monitor the INR, and your target INR should be between 2 to 3. Right? When you are using low molecular weight heparin, you have to monitor factor 10A, and your aim should be, it should be 0.8 to 1.2 international units per ml 4 to 6 hours after, administration of low molecular weight heparin. So target is 0.8 to 1.2, 4 to 6 hours after administration of low molecular weight heparin. And when you are using unfractionated heparin, you have to monitor APTT, that is activated partial thromboplastin time, and your aim is it should be 2 times the control value, right? Now, I'm also going to discuss a little bit about some clinical cases, and that is, suppose a patient is on warfarin at the time of delivery. You had to change the patient from warfarin to heparin at 36 weeks, but this patient did not come to you at 36 weeks, right? And she directly came to you at, at the time of her delivery, and patient is on warfarin. Now, what am I going to do? Now, I'm going to advise her to undergo cesarean section. Why? Because warfarin can cross the placenta, and because it can cross the placenta, it is going to lead to anticoagulation in the fetus also. And such fetuses, if I am going to, deliver them vaginally, they will have increased risk of intracranial hemorrhage. And that is why, in order to protect the fetus from having intracranial hemorrhage, I am going to do a cesarean section if patient is on warfarin at the time of delivery. But what if, suppose, patient is on warfarin and she's coming to you at the time of labor. She's 4 centimeters dilated or 5 centimeters dilated. Now what? Now in this case, you have to stop warfarin, and you are going to give injection vitamin K to the mother. And once the baby is born, you have to give injection vitamin K to the newborn baby. And because we do not have any antagonist for warfarin, I am going to replenish the clotting factors so that the mother's PPH is prevented. Right? And so I am going to give fresh frozen plasma to the mother. Right? So I'm going to give vitamin K to the mother. I'm going to give vitamin K to the baby once the baby is born. And I am also going to give fresh frozen plasma so that her PPH is prevented. Right? Now, suppose patient is on unfractionated IV heparin and patient goes into labor. As I told you, all anticoagulants, they have to be stopped before delivery, but patient is on unfractionated heparin and patient goes into labor. What then? Then nothing, stop heparin and continue the vaginal delivery. Now, suppose patient was on low molecular weight heparin and patient has gone into labor. As I told you, low molecular weight heparin, it is a little longer acting drug, right? And because it is longer acting, the chances of PPH in the mother are high. Over here, I am not worried about the baby because heparin doesn't cross the placenta. Right? So in this case, there is no need to do a cesarean section, but I am worried about PPH in the mother. So I'm going to stop heparin. I'm going to give protamine to the mother, and I'm going to continue with vaginal delivery. Clear to all of you? So over here, I just want you to read over here. So, although low molecular weight heparin does not result in anticoagulated fetus, the risk of maternal hemorrhage is high if delivery occurs while the mother is on low molecular weight heparin. Right? That is, therefore, it is recommended that the mother be hospitalized before planned delivery with discontinuation of long-acting anticoagulation and initiation of IV unfractionated heparin. Right? That is why we said that 1 week before delivery or at least 36 hours before her EDD, I'm going to change her from low molecular weight heparin to unfractionated heparin. Right? Okay. Coming to question number 9, which was a very easy question, and that was a question where there was an overlap between pharma and OBGY. It's an integration of OBGY and pharma. A pregnant woman was prescribed endomethacin. Which of the following effects does the drug have on the fetus? So if you've done your if you've watched your pharma lectures carefully and if you've watched your OBGY lectures carefully, at 2 places in OBGY, I have discussed this with you. Number 1, I have told you that endomethacin leads to oligohydramnios. And because endomethacin leads to oligohydramnios, it can be used in the management of polyhydramnios. And there I told you specifically that you are never going to use endomethacin beyond 32 weeks of pregnancy. Because if you use endomethacin beyond 32 weeks of pregnancy, it leads to, number 1, premature closure of the ductus arteriosus. So it's going to lead to premature closure of ductus arteriosus, and it may lead to renal failure also in the baby. Right? So that is why endomethacin is not used. The most common reason why it is not used is because it leads to premature closure of ductus arteriosus. Right? So this I have taught you in preterm delivery chapter as well, where we have discussed tocolytics, and I have discussed this with you in the chapter on amniotic fluid disorders as well. Right? So over here, I have a screenshot for you from Williams, and that says, SMFM recommends not administering endomethacin for the sole indication of reducing amniotic fluid. As noted above, in pregnancies less than 32 weeks of gestation with preterm labor, we sometimes use a short course of endomethacin for its combined effect of tocolysis and reduction of AFV, that is amniotic fluid volume. Adverse fetal effects including premature closure of ductus arteriosus and renal impairment are concerned when the drug is used for more than 3 days and when it is used for more than 30 weeks, at more than equal to 30 weeks. So to be safe, we never use it at more than equal to 30 weeks, but precisely you never use it at more than equal to 32 weeks, right? Because it leads to premature closure of ductus arteriosus, right? Okay. Coming to question number 10, again a question which we have discussed in our PPH video. A female patient after normal vaginal delivery developed atonic PPH. She was shifted to OT and the obstetrician planned to ligate the vessels to arrest the bleeding. What is the order of ligation of vessels supplying the uterus? So all of you know that uterus is supplied by uterine artery, and there is an anastomosis of uterine and ovarian artery, so it is also supplied by ovarian artery. And because uterine artery is a branch of anterior division of the internal iliac artery, so you have to ligate uterine artery, you have to ligate ovarian artery, and you have to ligate anterior division of internal iliac artery in case of PPH, right? So over here, uterine artery, ovarian artery, and internal iliac artery. And which division? Anterior division of internal iliac artery. So your answer is option A here. This I have discussed with you at 2 places. Number 1, in the management of PPH, and also I have discussed it where I am discussing with you the blood supply of the uterus in anatomy videos. Right? Quickly, let us talk about the management of PPH. So in the management of PPH, I told you that the first management is always a medical management where you have to give uterotonics, and the first choice uterotonic is oxytocin. So I'm going to give oxytocin, but the best drug always is PGF2 alpha. The first line drug is oxytocin, best is PGF2 alpha or carboprost. Right, so I'm going to do a uterine massage and I'm going to give these drugs for 30 minutes. Now, if after 30 minutes bleeding is not controlled, I'm going to go for mechanical method. And in mechanical method, you use a Bakri balloon catheter where the catheter is filled with warm normal saline, and maximum you can fill it up till 500 ml. Right? And suppose bleeding is not resolved even after this, then you have to see whether the vitals of the patient are stable or vitals are unstable. In case the vitals of the patient are unstable, then I directly go to the devascularization surgery. But if vitals are stable, then in that case, I have the option of doing two things. Either I can do a uterine artery embolization if interventional radiology facility is available in the setting. And if UAE, that is uterine artery embolization, cannot be done because interventional radiology department is not in your hospitals, then you are going to go for compression sutures like Beeling sutures, Gunchella sutures, or Cho square sutures, right? And if these fail, then you go to devascularization surgery. So after mechanical methods, you have to see whether the vitals are stable or unstable. If vitals are unstable, directly you go to devascularization surgery. If vitals are stable, then you first try UAE or you try for compression sutures. If it fails, then you come to devascularization surgery. And in devascularization surgery, the first vessel which I'm going to ligate will be a uterine artery followed by ovarian artery. Now, if after ligation of uterine artery and ovarian artery, still bleeding doesn't stop, now again I have to see whether the vitals of the patient are stable or unstable. If vitals are unstable, then directly I'm going to proceed to subtotal hysterectomy. But if vitals are stable, then I'm going to try ligating the anterior division of the internal iliac artery. And if that fails, then I'm going to go for subtotal hysterectomy. So this is the complete algorithm which you have to follow, and these are the steps which you have to follow when a patient comes to you with PPH, right? Now, coming to question number 11, which again is a repeat question, and it's an integration between pharma and OBGY. For a female with hypertension on preconception counseling, which drug should be avoided? So all of you know that if a patient has hypertension and she's trying to conceive, I'm going to avoid ACE inhibitors, and that was pretty easy. Other than ACE inhibitors, I'm going to avoid angiotensin receptor antagonist like losartan. We are going to tell her to avoid diazoxide. We are going to tell her to avoid beta blockers, and we are going to tell her to avoid diuretics. So these are the drugs which we have to tell her to avoid if she is planning pregnancy, right? So that was your OBS questions. Now we are going to do gynae questions. In gynae questions, the first question, that's an easy question where you could have related because I've taught you so much about SUI and prolapse in the videos on prolapse. A 56-year-old multipara woman presented with grade 2 or grade 3 uterine prolapse and cystocele. She complains of passing urine on coughing and sneezing. What type of urinary incontinence is seen in this patient? So what is happening here? Patient is having increased intra-abdominal pressure, and with increased intra-abdominal pressure, that is when she coughs or when she sneezes, there is complaint of involuntary passage of urine, and that is what is called as stress urinary incontinence. So from the very definition itself, you can make out that this is stress urinary incontinence, right? And please remember that in patients of prolapse, stress urinary incontinence is very common, right? But then that is occult. That means it's not visible, right? What do you understand by occult SUI? Occult SUI means in women without symptoms of SUI, occult SUI describes the finding of SUI that is apparent only during clinical or urodynamic urinary function testing when the prolapse is reduced. So what I want to tell you is that in patients of prolapse, I have told you this in videos also, in patient of prolapse, SUI is hidden, right? So suppose a patient comes to you with prolapse and you manage her, you do her surgery, and after surgery SUI is evident and you did not check for SUI before doing surgery, patient is going to accuse you that it is because of your surgery she has got SUI. That is why always in patients of prolapse you have to check for SUI before you check them for prolapse, right? And what is de novo urinary incontinence? This term is used to describe urinary incontinence that is newly symptomatic, typically after surgery in previously continent patient. So patient was previously continent. It was no hidden SUI. Patient was continent and after surgery patient has developed SUI. That is called as de novo urinary incontinence, right? Okay. So, now, why is it that in patients of prolapse, SUI is hidden. For that, I want you to see this image over here. So first see what this image is trying to tell you. Over here, in this image, what you are seeing is, see, this over here is bladder, right? And this is urethra. This over here is vagina. Right? Now, what is happening is patient is having cystocele, right? That means the anterior vaginal wall is prolapsing, and along with the anterior vaginal wall, it's a part of bladder which is also prolapsing. So you can see over here that a part of bladder has prolapsed. Now, because a part of bladder has prolapsed, there is kinking of the urethra. Can you see over here? There is kinking of the urethra. Right? So SUI was present in this patient. This is a patient of prolapse, and this patient had SUI. Why does SUI happen? SUI happens because of descent of bladder neck. So this patient had SUI, and this SUI was not related to her prolapse, right? But because of prolapse, her SUI is hidden. Why it is hidden? Because the urethra is getting compressed. Can you see kinking of this urethra? Now, because the urethra is getting compressed, because there is kinking of urethra, that is why her SUI is not evident. Now, when I am going to replace her bladder in normal anatomical position, like they have showed in image B. Now, the moment the bladder is replaced in its normal anatomical position, that compression of the urethra is gone, right? And patient again will show you symptoms of SUI, right? So, I'm not saying that in prolapse is leading to SUI. Rather, what I'm telling you is that in patients of prolapse, SUI is hidden. It is not evident. Right? And this is something which I told you in this question also. If you remember in videos, I told you before examining for prolapse, you have to check for SUI. What is the best method for checking for SUI in patients of prolapse? So that means that you have to put the prolapse part inside, and then you have to check for SUI. You have to restore the normal anatomical position. And are you going to do this with a full bladder or empty bladder? So common sense tells me that if I have to check for SUI, I have to do it with a full bladder, and I have to put the prolapse part back in its normal anatomical position, and I have to tell the patient to cough, and then only I will come to know whether the patient has SUI or not. Please remember, for examining prolapse, right, you have to empty the bladder and you have to examine prolapse when the prolapse part is out. So before you tell the patient to empty her bladder so that you can see her prolapse, that what degree prolapse it is, you should always check for SUI with full bladder and with prolapse part inside in its normal anatomical position, right? Coming to next question, a 28-year-old married woman who was anxious to conceive presents with copious vaginal discharge without itching. She had her last menstrual period 13 days back. What is the cause for her discharge? So I'm sorry for this one. I did not expect that a question on leukorrhea is going to come. Right? And I have not taken, I'm not going to make any false claims. I did not teach leukorrhea in edition 4 also and in edition 5 also. But yes, you can come to a diagnosis over here. All of you are smart enough, and I don't think so anyone would have done this question wrong, especially when they are saying that patient had periods 13 days back. That means this is her time around ovulation, and around ovulation, estrogen levels are high, and all of you know that it is estrogen which leads to thin, watery, copious cervical mucus. And because estrogen leads to thin, watery, copious cervical mucus, so near the time of ovulation, patient has physiologically increased vaginal discharge, and this physiologically increased vaginal discharge, that is what is called as leukorrhea also. And here the discharge is thin, watery, and it is mucoid. It doesn't have any color, right? It is a white color discharge or a mucoid discharge. There is no pruritus, no itching, and there is no foul smell, right? So over here also, patient did not have any itching. There is no foul smell over here. If it would have been a case of bacterial vaginosis, typically they would have given you the history of foul smell, because patients of bacterial vaginosis, the discharge discharge is grayish in color and it is foul smelling discharge. Yes, pruritus is not present in bacterial vaginosis discharge also, but then foul smell is present, and because over here there is no foul smell and this is happening typically around the time of ovulation, we say that this is physiological discharge which is happening because of excessive estrogen. Right? Now, I just want you to understand one or two things because timing of symptoms is also important. So please remember that candidal discharge, it occurs in the premenstrual period. So most of the times in the premenstrual period, if patient is coming to you with discharge, with itching, with curdy white discharge, right, that is a candida. And whereas discharge of trichomonas and bacterial vaginosis, they occur either during menstrual period or immediately after the menstrual period, right? Symptoms that develop soon after sexual intercourse. So if patient is having discharge soon after sexual intercourse, she starts having discharge, they are suggestive of sexually transmitted infections. And symptoms that develop after gynecological surgery, that is hysterectomy, then that is suggestive of vaginal fistula. So based on the timings also, you have to remember which discharges are more common at what particular time, right? Coming to question number 14, a 30-year-old married woman came for infertility evaluation. On further investigation, intramural fibroids of size 7 into 5 centimeters and 5 into 3 centimeters were found at both right and left cornual ends of the uterus respectively. Her husband's seminal analysis was found to be normal. What is the appropriate management in this case? And again, this is something which we have discussed in our videos. In the videos, I told you that even if patient is asymptomatic, right, that means patient is not coming to you with excessive bleeding, but there is fibroid seen and there is patient has history of infertility or patient has history of recurrent abortion and all other investigations you've done and other investigations do not suggest anything, then it is an indication for treating even an asymptomatic fibroid. So over here, all other investigations are normal. Patient has come to you with infertility. She doesn't have any excessive bleeding because of the fibroid. But because all investigations are normal and because she has infertility, probably her infertility is because of these two fibroids which are near the cornual end. So even if it is asymptomatic, I will have to manage it. I will have to do a surgical management and I will have to go for myomectomy. Please remember, over here, fibroids are near the cornual end of the tube. So ART will be of no use, right? ART is done, that is IVF is done when there is a tubal pathology. Right? So over here, the problem is not a tubal pathology, right? So IVF is not the answer over here. Over here, you are going to go for myomectomy. Uterine artery embolization is not done if a female desires pregnancy in future. And as far as GnRH analogs are concerned, GnRH analogs are going to decrease the size of the fibroid and they are the management of fibroid when the fibroids are symptomatic fibroids. Right? For management of infertility due to fibroid, you will have to go for myomectomy, even if it is asymptomatic. Right? So, over here, now I know that I'm going to go for myomectomy. Now, the next question which I want to ask you is, what is the route of myomectomy which you are going to adopt? Please remember that in case of intramural fibroids, I'm going to go for a laparoscopic myomectomy. In case of submucous fibroid, which is type 0 or type 1, you have to go for hysteroscopic myomectomy. And for submucous type 2, you have to go for laparoscopic myomectomy. Right? So either laparoscopic or abdominal depending upon other criterias. Clear to all of you? So you have to do a myomectomy for intramural fibroid. It has to be laparoscopic myomectomy or an abdominal myomectomy, not a hysteroscopic myomectomy. Right? So again, I am just making you read these lines so that you know that from where the reference has been taken. This is from the up-to-date. So all fibroids other than submucosal for patients who desire pregnancy and they present with bulk symptoms or whose fibroids are not amenable to hysteroscopic resection, we suggest abdominal myomectomy either by laparoscopy, right? Myomectomy is typically the first option, right? So over here, patient is desiring pregnancy, right? And with or without bleeding. So patient wants pregnancy, right? She desires pregnancy and patient has come to you with or without bleeding. In case of intramural fibroids or in case of all those fibroids where hysteroscopic resection is not possible, and that is type 2 submucous fibroids or intramural fibroids, you are going to go for myomectomy, which could be either abdominal route or by laparoscopic routes, right? So over here, now suppose patient doesn't desire fertility and patient has come to you with complaint of heavy menstrual bleeding. Now what? Now if patient comes to you with heavy menstrual bleeding and if it is a case of submucous fibroid, then the first line management again is myomectomy. Right? For a submucous fibroid in heavy menstrual bleeding or in symptomatic fibroids, the best management is myomectomy. Again, type 0 and type 1, you are going to do a hysteroscopic myomectomy. Whereas in type 2, you are going to go for abdominal myomectomy or laparoscopic myomectomy. For all other fibroids, like for example, intramural fibroid or subserous fibroid who are coming to you with complaint of heavy menstrual bleeding, the first line management are the drugs which decrease the bleeding and they do not have any effect on the size of the fibroid. And what are those drugs? Oral contraceptive pills and progesterone. So the first line management is OCPs and progesterones. Now, if first line management fails, then I'm going to go to the second line management. And what is the second line management? Second line management is you can go for procedures like uterine artery embolization, or you can go for drugs which decrease the size of the fibroid and they are GnRH agonist, antagonist. Then you can use ulipristal, you can use mifepristone. Right? So these are the second line drugs for managing intramural and subserous fibroids, which have patients who've come to you with excessive bleeding. Now, what is the third line management? Third line management is high intensity focused ultrasound. Please remember that uterine artery embolization and high intensity focused ultrasound, they can be done in premenopausal females. They cannot be done in those females who want pregnancy in future. You cannot do it in those females. Right? Now, suppose patient has come to you with pressure symptoms. So now when a patient is coming to you with pressure symptoms, obviously the pressure symptoms are happening because of the size of the fibroid. So you will have to do something to decrease the size of the fibroid. And in order to decrease the size of the fibroid, either I'm going to go for a uterine artery embolization, right? Obviously, if the blood supply to the fibroid is decreased, the blood supply to the uterus is decreased, the blood supply to the fibroid will be decreased, and so the size of the fibroid will shrink, right? So either I'm going to go for a uterine artery embolization or I'm going to use drugs which decrease the size of the fibroid. In other words, I'm going to use GnRH agonist or antagonist. Now, in all these situations, suppose there is a patient whose family is complete and she says, I want a definitive treatment. So definitive treatments are myomectomies and hysterectomy anyways, right? Now, I am telling you a little more detail over here because if a question has been asked on management of fibroid, you need to know a few more details over here. Suppose if they ask you what are the contraindications for hysteroscopic myomectomy. So one contraindication is a type 2 submucous fibroid or intramural fibroid. So any fibroid which is more than 50% extended into the myometrium. Right, that will be a contraindication for hysteroscopic removal. Apart from that, you have to see that there shouldn't be any general contraindication to hysteroscopy as such. So what are the contraindications to hysteroscopy? Contraindications to hysteroscopy are active pelvic infections, pyometra, cervical or uterine cancer, and pregnancies. right? Now, if I ask you what are the limitations of uterine artery embolization, the limitations of uterine artery embolization are that although yes, this has got a high success rate, there are approximately 25% risk of subsequently undergoing hysterectomy. So patients who undergo uterine artery embolization, ultimately 25% of them are going to undergo hysterectomy later on. Right? Then this procedure should be done in premenopausal females only. You cannot do them in females who want pregnancy in future, number one, and you cannot do it in a postmenopausal female also, because it could be by mistake you are treating a uterine sarcoma instead of a leiomyoma. Right? So because the chances of uterine sarcoma are present in postmenopausal females, so in a postmenopausal female, I am not going to do a uterine artery embolization. In a postmenopausal female, if fibroid has to be removed, I will do a hysterectomy only, so that once the tumor has been taken out, the sample uterus has been taken out, I can send the entire uterus for histopathological examination and I can come to know that whether sarcoma was there or not, and I can be sure. Right? So I'm not going to do a uterine artery embolization in females who want pregnancy in future, and not in postmenopausal females also who come to me with fibroid. Right? Then uterine artery embolization is not able to treat fibroids which are supplied by cervical or ovarian arteries. Yes, because you are embolizing uterine artery. So if a fibroid is being supplied by cervical artery or ovarian artery, definitely you cannot treat it by uterine artery embolization, and is not generally indicated for uterus size greater than 20 weeks. So if the size of the uterus is more than 20 weeks, I cannot go for uterine artery embolization. Then uterine artery embolization can rarely precipitate menopause in patients who are 45 years or older at the time of treatment. And females who want future childbearing, you are not going to do uterine artery embolization in them. Clear to all of you? Yes. Then who are the ideal candidates for high intensity focused ultrasound? High intensity focused ultrasound is also called as magnetic resonance guided focused ultrasound. Right? So MRGFUS, that is also high intensity focused ultrasound. Now in high intensity focused ultrasound, you make the patient lie down and you focus the ultrasound rays on the fibroid. And the best candidate for such thing is the number of fibroids, they should be less than equal to 3. The size of the fibroid in the largest dimension, it should be less than 10 centimeters, and there shouldn't be any calcification in the fibroid. So the number should be less than 3, size should be less than 10 centimeters, and there shouldn't be any calcification. Right? Now, I have told you ideal candidate for hysteroscopic myomectomy. Now, who are the ideal candidates for laparoscopic myomectomy? Now, for laparoscopic myomectomy, fibroids other than type 0 and type 1 submucous fibroids, you can go for laparoscopic myomectomy if the size of the uterus is less than 17 weeks pregnant uterus size, and if the number of fibroids is less than 5. So please remember that for HIFU, the size was less than 10 centimeters and number less than 3. For laparoscopic myomectomy, size is less than 17 17 weeks pregnant uterus size and number less than 5. And for uterine artery embolization, size was less than 20 weeks pregnant uterus size. So these are small things which you have to remember about them, right? Coming to question number 15, again one of the very controversial questions, but if you have watched my videos properly, you will be able to answer this question correctly, although many people are giving on many platforms various incorrect answers, but my answer is based on Leon Spiroff. So I'm going to tell you an answer based on textbook reference, and this is Leon Spiroff 9th edition page 885, which I'm going to tell you the answer. And if you've watched my video properly, you would have given this answer correctly. So there is a woman who's taking combined oral pills, visits peripheral hospital with history of missed pills on 4 different days in the first 2 weeks of menstrual cycle. What is the safest advice to give to the patient, right? So she's missed 4 pills on different days, and this has happened in the first 2 weeks of starting the pill. right? Now, I have told you in the videos that if one pill is missed, then that one pill is not going to interfere with the contraceptive efficacy as ovarian suppression is maintained. So, if one pill is missed, nothing to worry. You just have to tell the patient that whenever she remembers, she has to take the missed pill and she has to continue the schedule as it is and no backup is needed, right? So, if one pill is missed, so next day, whenever she remembers, she's going to take that one pill, right? And she will continue her schedule. So that means effectively she's taking 2 pills on that day, right? One missed pill and one she's continuing with the schedule and no backup is needed, right? Now, if 2 pills are missed, then you have to see in which week these 2 pills are missed. If 2 pills are missed in week 1 or week 2, then she has to take 2 pills daily for the next 2 days. She has to finish the pack and backup is needed for 7 days, right? But if 2 pills are missed in week 3, then she has to start a new pack. She has to just forget about that cycle. She has to start a new pack and she has to use a backup for 7 days. Now, if 3 or more pills are missed, in that case, irrespective of what time these 3 pills are being missed, she has to start a new pack and a backup is needed for 7 days, right? So, in this question, they are saying 4 pills are being missed. Now, when we say 3 or more pills are being missed, these 3 or more pills which are being missed, they could be on consecutive days or they could be on different days. So, because over here 4 pills are being missed, what are you going to advise her? You're going to advise her, stop that cycle, start a new pack, right? And for 7 days, take alternate method of contraception. Now, this is the answer if this was the question, right? Now, suppose your question, as some of you are saying that, ma'am, it was given that 2 pills are missed. 2 pills were missed consecutively. So, if 2 pills were missed consecutively and others were missed at different times and 2 pills were missed consecutively, then your answer will be based on this, which means you have to take 2 pills daily for next 2 days and you have to use a backup method of contraception, right? And you have to continue with the schedule. So if that was the question, then you have to take the most recent pill missed immediately, use a barrier method of contraception for 7 days, and yes, emergency contraception should be used if unprotected intercourse happened in last 72 hours. That is if your question did say that most recently she has missed 2 pills, overall she missed 4 pills. But if your question is as per this, where they are just saying that 4 pills are being missed on 4 different days in the first 2 weeks of menstrual cycle, then definitely your answer is option B, based on what Leon Spiroff 9th edition page 885 says. Just one thing which I want to tell you over here is, even if pills are not missed, but patient has history of gastroenteritis. So if you have a female who has vomiting, who has diarrhea, and even if she doesn't miss any pills, please tell her that she has to use a backup for 7 days. Because one of the very common reasons for OCP failures is not missing of pills. It is because she had vomiting and diarrhea and her, GI absorption was not happening of the OC pills. So even if she did not miss any pills, you are going to tell her to use a backup method for 7 days. She will continue taking her pills, but she has to use a backup method for 7 days, right? Question number 16, that's a very easy one. A female had miscarriage 3 times. Identify the investigation shown in the image. So over here, you are seeing a Leach-Wilkinson cannula, right? And you are seeing that a dye has been passed into the uterus. So you know this is a case of hysterosalpingography, right? And when is HSG done? HSG should always be done in the pre-ovulatory phase between day 7 to day 10. Right? And what is the cannula which is used? As I told you, it is a Leach-Wilkinson cannula. What are contraindications for using HSG, for doing HSG? Number 1, if there is active pelvic infection. Number 2, if there is genital tuberculosis. Number 3, if there is a suspected pregnancy. Or number 4, if there is allergy to the dye which you are using. Right? So these are contraindications for using HSG, for doing HSG. Right? Coming to question number 17, again, that's a very easy one. You would have done it if you would have watched my videos properly. A 32-year-old married woman who came for evaluation of infertility was found to have a septum in the uterine cavity. What would be the appropriate management in this case? Now, if a septa is present, I've always told you that the management of septa is hysteroscopic resection of the septa. And instead of saying hysteroscopic resection of the septa, over here the option which is given is hysteroscopy and septoplasty. So you're not going to do hysterectomy, you are not going to do laparoscopy and metroplasty or laparotomy and metroplasty. What you're going to do is hysteroscopy and septoplasty. I have told you in the videos also that the outdated technique for managing septa is Tompkins metroplasty and Jones metroplasty. For Strassman metroplasty is the surgery which is done for bicornuate uterus, right? So over here the answer is hysteroscopic septoplasty. Question number 18. A teenage presented with history of dysmenorrhea and chronic pelvic pain. On ultrasound, a transverse vaginal septum was seen. What is the most common complication seen in this patient? Now, this is a question which I have taught you in endometriosis. If you remember, in endometriosis, I told you that whenever endometriosis is seen in a teenage girl, you should always suspect that they have Mullerian malformations. You should always rule out Mullerian malformations, right? So this is how we did it in videos. Now, understand, in Mullerian malformations, whenever there is an obstruction to the outflow tract, now that obstruction could be partial or that obstruction could be complete. What it is going to do, it is going to promote retrograde menstruation because of the obstruction, blood will be collected in vagina, blood will be collected in cervix, and blood will be collected in the uterus. So because of the obstruction, there will be hematocolpos, hematometra, hematosalpinx, and ultimately that is what leads to retrograde menstruation. And retrograde menstruation leads to endometriosis. The most common theory which explains endometriosis, all of you know, it is the theory of retrograde menstruation, that is also called as the theory of implantation, which was given by Sampson, right? So whenever there is obstruction in a patient of Mullerian malformation, chances of endometriosis are very high. And I also told you, whenever endometriosis is seen in a pubertal female and you are suspecting endometriosis because of the symptoms of endometriosis, and over here there is dysmenorrhea, chronic pelvic pain, so that is a symptom of endometriosis, and patient has transverse vaginal septum. So transverse vaginal septum, history of dysmenorrhea and chronic pelvic pain in a teenage female leave no doubt that it is a case of endometriosis. Now, I want you to read these lines from here. In non-pregnant patient, congenital uterine anomalies that obstruct or partially obstruct the flow of menses, right? And what can be those anomalies? A non-communicating functioning uterine horn, uterine duplication with obstructed hemivagina, uterine septum with an obstructed hemivagina. So all these are conditions which can lead to endometriosis, which can lead to hematometra, hematocolpos, retrograde menstruation, development of endometriosis, pelvic pain, abnormal uterine bleeding, and genital tract infection, right? Now, why I made you read this is because of this line, uterine duplication with obstructed hemivagina. Uterine duplication with obstructed hemivagina, this is what is uterine didelphys. So in uterine duplication with an obstructed hemivagina, so there are cases of uterine didelphys where you get hemivagina. So one more question was there in your NEET PG, and that was this question. A 27-year-old female was found to have uterine didelphys. Which of the following is not a likely complication of this uterine anomaly, right? Now, if you have a uterine didelphys, abortion will happen, preterm labor will happen, right? Now the confusion is between endometriosis and transverse lie. So as I told you, in uterine didelphys, you can either have a normal vagina, right? So in videos we have done this in the videos. You know what is a uterine didelphys? So what's a uterine didelphys? Uterine didelphys is when there is, in uterine didelphys, you have two uterus, two fallopian tube, you have two cervix. Vagina, it can be single, it can be two, right? Or they can be a septum. This is what I have made you write. So when there are two uterus, two cervix, vagina, it could either be single or they can be two vagina or they can be a septum. So this is what is a uterine diadelphus, and this is how you recognize it with two cervix. If two cervix are present, it has to be a uterine diadelphus. In case of bicornuate uterus, always there is a single cervix. Right? So over here, what I'm saying is a uterine diadelphus, two uterus, two cervix, and single vagina. So uterine diadelphus with normal vagina. And this is uterine diadelphus with a complete vaginal septum. So in a uterine diadelphus, there can be a vaginal septum, and that vaginal septum may be a complete vaginal septum or an incomplete vaginal septum. And because of all this, obstruction can happen. Right? So let us read what is written over here about uterine diadelphus. Uterine diadelphus or double uterus is a duplication of reproductive structures. Generally, the duplication is limited to the uterus and cervix. Right? Although duplication, okay, that is right, 15 to 20% of patients with diadelphic uterus also have unilateral anomalies such as obstructed hemivagina and ipsilateral renal agenesis. Right? So obstructed hemivagina may be seen in uterine diadelphus, and just now I told you whenever there is obstruction that leads to endometriosis. So over here in clinical significance they have given spontaneous abortion can happen, preterm birth can happen in uterine diadelphus, IUGR, fetal growth restriction can happen, right? And a septated vagina can be present, and that may make sexual intercourse, difficulty in sexual intercourse. And patients with obstructed hemivagina, they will have regular menses because menstrual blood from one uterus can egress through its non-obstructive cervix and hemivagina. However, such patients are most likely to develop cyclical pain due to building of blood in obstructed hemivagina. Right? So over here, these patients, they can be accumulation of blood because of obstructed hemivagina, and just now we did that accumulation of blood can lead to endometriosis. So definitely the answer to this question is transverse lie. Endometriosis can be seen in patients of uterine diadelphus if there is obstructed hemivagina also, which is one of the components of uterine diadelphus in some patients, right? But transverse lie is not seen in uterine. It's not that common in uterine diadelphus. Transverse lie is more common with a septate uterus. It is more common with a subseptate uterus and with bicornuate uterus. Malpresentation, which is more common in diadelphic uterus and unicornuate uterus, is breech, right? So over here, don't get confused. Don't think about any other thing. What I'm telling you is correct. The answer to this question is transverse lie. Endometriosis is seen in patients of uterine diadelphus, right? Coming to question number 20. The ultrasound of a young female with infertility is suggestive of a uterine anomaly. Which of the following is used to confirm the diagnosis? So HSG, hysteroscopy and laparoscopy and TVS. Now, over here, again, this question you can answer. Why? Because over here, HSG is not the investigation of choice. All of you know that by HSG, you cannot see the external contour of the uterus, right? So let me tell you a stepwise approach to Mullerian malformations. In the videos also, we have covered this. Stepwise approach is that first investigation, which is generally done to know whether Mullerian malformation or rather accidentally Mullerian malformation is found on that investigation, and that is TVS. So when patients come to you with complaint of infertility or they come to you with recurrent abortion, you order a TVS, and on TVS you come to know, oh, this patient has Mullerian malformation, right? But the investigation of choice is not TVS. Investigation of choice is 3D ultrasound. HSG is also not the investigation of choice. Why? Because with the help of HSG, the external contour of the uterus cannot be seen. And HSG cannot differentiate between bicornuate and septate uterus. As you can see over here, image A is septate uterus, image B is bicornuate uterus. Now, when I'm going to fill a dye in them, right? So when they will be filled with the dye, this is how the dye will go in septate uterus, right? The area of the septa will be avoided. So over here, the dye will not penetrate into the area of the septa. So this is how you are going to get the image in septate uterus, right, on HSG. And same over here in bicornuate uterus. Same image you are going to get in bicornuate uterus. So HSG cannot differentiate between septate and bicornuate uterus. In order to differentiate between septate and bicornuate uterus, you have to look at the contour of the uterus. In case of septate uterus, the external contour of the uterus is normal. Whereas in case of bicornuate uterus, there is a dipping. The fundus is dipped in case of bicornuate uterus. In septate uterus, uterus appears normal. The fundus of the uterus appears normal from external view, right? So externally viewing the uterus is very important whenever you have to differentiate between septate and bicornuate uterus, and that is why HSG is not the investigation of choice. The gold standard investigation in case of uterine malformations is MRI, which is a non-invasive technique. Although we can go for laparoscopy and hysteroscopy also. With the help of laparoscope, you will see the external contour. With the help of hysteroscope, you will see the inside. But then laparoscopy and hysteroscopy, that's an invasive procedure, right? So the best answer always for the gold standard investigation is MRI. But over here, they have not given you MRI. They have given you just laparoscopy, transvaginal ultrasound, and hysteroscopy and laparoscopy. So now the answer over here will be hysteroscopy and laparoscopy, right? Coming to the last question, a 26-year-old female with history of easy fatigability and constipation for the past 1 year. She had history of multiple blood transfusions after delivery 4 years back, right? So multiple blood transfusions after delivery definitely means she was having PPH. She had lactation failure and she never regained her periods after a delivery. So this is a very easy one. Patient is coming to you with PPH, right? And after delivery, she did not regain her periods and she has lactation failure after that. So undoubtedly, it's a case of Sheehan syndrome, and all of you are smart enough to answer this question from the video itself. So Sheehan syndrome, what is Sheehan syndrome? It is ischemic necrosis of the anterior pituitary gland, which happens due to PPH. All anterior pituitary hormones are decreased, and because LH and FSH are decreased, so patient complains of amenorrhea. Because prolactin is decreased, so patient complains of lactational failure. Because TSH is decreased, patient will complain of cold intolerance, and because ACTH is decreased, so the adrenal glands will not produce androgens, and it is the adrenal androgens which lead to pubic hair and axillary hair development. So there will be loss of pubic hair and axillary hair. So this question over here is of Sheehan syndrome. Whenever you are getting that patient is not having a periods, there is lactation failure, right? And they are telling you that indirectly they are giving you history of PPH. So undoubtedly it's a case of Sheehan syndrome. Clear to all of you? From this exam, what I could make out was that the questions which were asked were easy. They were from those topics which were very relatively easy topics. But you have to be very careful when you are reading a topic. You have to, you just cannot have superficial knowledge. Superficial knowledge is not going to help you. You will have to build your concepts and you will have to remember each and every line what I tell in the videos. And so many of you do say na that ma'am, you teach so much in the videos. Marrow is little bulky than other places. That is why our videos are lengthy. That is why our notes are bulky, because we are not going to let you leave any question, any concept. One question I didn't teach you. Leukorrhea I didn't teach you. Physiological discharge I didn't teach you, and that was there. Right? So we cannot afford to do that when your future is at stake. We have to teach you everything, and you are a doctor. Your knowledge is never going to go waste if you are studying more, but your ear will go waste if you are studying less. So on this note, prepare well and keep studying. So now, after discussing the all recall questions of NEET PG 2021, let's discuss the questions which were asked in INI CET July 2021 session in Obs and Gynae, right? But before I start discussing with you the questions and the correct answers and explanations, let's see a little bit about how the INI CET paper was and what was the paper analysis. Now, when you look at the Obs and Gynae questions which were asked in INI CET July 2021 session, question. There were around 21 questions. And again, in these questions, there were many straightforward questions which you could answer if you have watched all the videos properly. And the single liner straightforward questions, there were 4. 1 question on active management of third stage of labor, 1 on twins, 1 on anatomy, and then there were questions on pap smear. Now, overall, image-based questions, we had 2 spotters, we had 1 ultrasound, and there were instrument-based questions also. So they had shown you an instrument of pap smear and they had asked you instruments of cesarean section. Then this time in INI-CET, there was a lot of focus on investigations rather than on management, and there were 4 questions which were asked on investigations, and there was a lot of focus on disorders of sexual development. Again, as far as OBGY is concerned, I can tell you with confidence that if you watch all the videos of Marrow properly, and when I say all the videos of Marrow properly, I not only mean that you have to watch just the main videos. You also have to watch the videos which we keep on putting in between. For example, the We Are With You session. That is a very, very important session where we have given you a lot of, practice on clinical MCQs. Then integrated sessions, right? So those integrated sessions, they are those questions which are potential questions. And these are those questions which will help you in building the concepts. Then I want all of you to be very careful on all the videos which we keep uploading on the Marrow YouTube live channel, Marrow live channel on YouTube. For example, instrument questions. There is a video which I have given on instruments in Obs and Gynae, and this time there were directly questions from those videos. There were 3 questions which were there from those videos. 1 on pap smear, then on cesarean section, and on uterocervical length. So when we say that you have to watch Marrow videos, that is not just the main videos. All the additional videos which we keep giving you, that has to be watched, right? Then management, there was just a very simple question on the management of PCOS. Again, they were integrated questions, but they were very simple integrated questions. 1 was integration between OBGY and physiology, 1 between micro and OBGY, and 1 between anatomy and OBGY. And there were 2 questions which had multiple correct answer types, right? So this is the overall paper analysis. And if you ask me what I'm seeing, the general trend these days, when we look at the NEET PG paper and we look at the INI-CET exam paper, there is a lot of focus on gynae these days, contrary to OBS, right? So that doesn't mean that you're not going to study OBS, but earlier, you people used to lay a lot of focus on OBS and less focus on gynae. So please have a very, very balanced approach. Gynae questions are increasing these days. So that means you have to read topics like congenital malformations, like disorders of sexual development, like cancers, fibroid, endometriosis, PCOS. All these becomes very, very important topics for all of you, right? So let's get going. This is your first question, which I'm going to discuss with you. And the first question is, they have shown you an image and they say, a doctor tells a 31-year-old woman who's 20 weeks pregnant that her baby has a developmental defect. She has come for second opinion. The following ultrasound is seen. Identify the defect. Right. So in this ultrasound, again, see, this is an integration between OBGY and radiology, right? So over here, what I'm seeing is that the eye socket over here is very big. And over here, you can see irregular brain tissue, right? So over here, you can see that the skull is not properly formed, right? So if the skull is not properly formed and if you are getting big eyes, that means it is anencephaly. In anencephaly, this is the image which we show you in class, and in this image you see that there are big eyes, which is called as frog eye, and you can see over here that the brain tissue has herniated out. Brain tissue is, it is out. There are no meningeal covering. There is no skin. There is no skull. And that is what is anencephaly, right? So this over here is an image of anencephaly. But I want all of you to see that in the options, you had anencephaly, you had omphalocele, you had cystic hygroma, and you had encephalocele. Right? Now, anencephaly and encephalocele, both of them are neural tube defects, right? How am I going to differentiate between anencephaly and encephalocele? We'll just do just now. And omphalocele is an abdominal wall defect, and cystic hygroma, that is a lymphatic defect which happens. Now, all these four are important when it comes to INI CT or when it comes to your any future exam which you are preparing for. But that is how you have to approach a question. You just don't have to know the correct answer. You also have to know about the other options which are given in that particular MCQ. So I'm going to briefly tell you about the embryology of the central nervous system. So in the embryology of the central nervous system, you have to remember that CNS, the central nervous system of the fetus, it develops from ectoderm, and there is a thick plate of ectoderm which will form the neural plate, right? So it is going to form the neural plate. Now the lateral margins of the neural plate, they are going to fold, and that is how a neural fold will be formed. Right? So a neural fold is going to form. Now this neural fold, it is eventually going to fuse, and this fusion which is going to happen, it is going to begin from the cervical area, and then it is going to go upwards and downwards, right? So in the cervical area, the fusion begins, and it again goes caudally, cranially, and it goes caudally as well. Right? So the cranial neuropore, or which is called as the rostral neuropore, it fuses around day 25 after ovulation. So day 25th of fertilization, whether I say to day 25th of ovulation or day 25th of fertilization, it's one and the same thing, right? So day 25 after fertilization, the rostral neuropore or the cranial neuropore, it closes, whereas the posterior one, that is the caudal one, it is going to close by day 27. That is 2 days after the rostral neuropore closes. Now suppose this, and that is how a neural tube is formed. Right? Now, anencephaly and encephalocele, both of them are neural tube defects, right? So there is a problem in the formation of this neural tube. Now, suppose this cranial neuropore, it doesn't fuse at all. What is going to happen? This is going to result in herniation of the entire brain tissue. Not only that, this brain tissue will not be surrounded by any meninges. So there will be absence of skull and meninges. And this is what is called as anencephaly. In anencephaly, there is absence of skull. Right? So there is acrania, there is absence of skull, and the brain tissue, it lies directly outside. So this is how you get in anencephaly. The brain tissue is exposed. There is no skin covering, there is no meningeal covering. Right? And anencephaly is one of those congenital anomalies which is detected earliest on ultrasound. Right? So if they ask you which congenital anomaly can be detected earliest on ultrasound, that is anencephaly. Anencephaly can be earliest diagnosed by 10 weeks, and definitely it can be diagnosed by 14 weeks on ultrasound. Now in anencephaly, we get two signs. One is a triangular face, and this triangular face, this is what is called as the Mickey Mouse sign, and you get big bulging eyes, that is frog eye sign. And this is what I told you, you are going to get a triangular face and a bulging eyes. Now this herniated brain tissue or the exposed brain tissue, so it's not herniated, we are going to say it's a exposed brain tissue. This exposed brain tissue, it gives a sign, and that is called as a shower cap sign on ultrasound. Please remember that anencephaly is the most common neural tube defect, and it is not compatible with life. It is more common in females. So this is again very important point. Recurrence rate of anencephaly is 5%. In anencephaly, there is adrenal glands hypoplasia. Face is absolutely normal in anencephaly, and that is why if someone asks you what is the most common presentation in anencephaly, it's the face presentation. Patients of anencephaly, their mothers are going to have polyhydramnios, and alpha-fetoprotein levels are increased in anencephaly, but it is not the most specific biochemical marker of anencephaly. The most specific biochemical marker of anencephaly is acetylcholine esterase, right? Now, what about encephalocele? Encephalocele is also a neural tube defect. Here, there is a small defect in the neural tube, and through the small defect, the brain tissue herniates out, but but this brain tissue is enclosed by skin, right? So here skull is present. In anencephaly, skull was absent and the entire brain tissue was lying exposed. So it was an open defect. Whereas encephalocele is a closed defect where through a small defect, the brain tissue is coming out, but it is covered by meninges and it is covered by skin. Right? Please remember that mostly this defect is going to happen in the squamous part of the occipital bone. Then you have another neural tube defect, which is spina bifida, and ultrasound of spina bifida is also very important. All of you know that in spina bifida, you are going to get bossing of the frontal bone, and that is what is called as the lemon sign, right? And you get downward elongation of the cerebellum, which is called as the banana sign. Then comes omphalocele. Omphalocele, that's an abdominal wall defect. Now, omphalocele, it should be differentiated from gastroschisis. As you can see in this image over here, in omphalocele, the herniated abdominal contents, they are enclosed in a sac or in a covering. Whereas in gastroschisis, the herniated contents, they are not in a sac. Right, so on ultrasound, if you are getting that the abdominal wall contents have herniated out and they are, if there is a smooth outline, that means they are in a covering, that means it's omphalocele. But if abdominal wall contents have herniated out, but there is, you can see that there is no covering because they are irregular, right? That means no covering is present and that means it's gastroschisis. Before I move any further, one very other important point which you have to remember is that herniation of bowel loops, that is, please remember, it is physiological up till 8 to 11 weeks of pregnancy. So whenever you have to make a diagnosis of omphalocele, it should always be made after 11 weeks of pregnancy, right? And what about cystic hygroma? Cystic hygroma is multiloculated lymphatic lesion, which is generally present in the posterior triangle of the neck. And cystic hygroma, it should be differentiated from nuchal translucency. What is nuchal translucency? Nuchal translucency is collection of fluid which is happening in the subcutaneous area just below the neck, right? So over here, this is what is, the nuchal translucency. So this image is showing this is normal collection, and over here what you are seeing that the collection below the neck has increased, right? That means there is increased nuchal translucency. So if there is increased nuchal translucency, it is a marker for aneuploidy and also it is a marker for congenital heart diseases. Now, increased nuchal translucency, it should be differentiated from cystic hygroma. In both of them, you are going to see that below the neck of the fetus, there will be collection of fluid. But in case of cystic hygroma, it is going to be more extensive, right? Over here, you can see it is small, but over here, it is going to be more extensive and you may see presence of septa. So if you are seeing presence of septa and you are seeing that the fluid collection is more widespread, that means you are dealing with cystic hygroma. Please understand that cystic hygroma in itself is also a marker of aneuploidy, right? So this is how you can differentiate between nuchal translucency and cystic hygroma. Coming to question number 2. Question number 2 was a straightforward question, but as I told you, these are recall questions and I have got 2 formats for this question. Some of you are saying that the question was, which of the following is a part of AMTSL? What is AMTSL? Active management of third stage of labor. And the options were option A, uterotonic after the delivery of the placenta, controlled cord traction, uterine massage, and early cord clamping. So, some of you are saying the question was, which of the following is not a part of active management of third stage of labor? And the options were injection uterotonic, early cord clamping, controlled cord traction, and uterine massage. Nevertheless, what was the question? First, let us see what are the components of active management of third stage of labor, and then we'll discuss the answer to both the formats of the questions. So active management of third stage of labor, which is the best method to prevent PPH, it has got 4 components. The first component is injection uterotonic. But when are you going to inject this uterotonic? Are you going to inject this uterotonic after the delivery of the placenta? No. This injection uterotonic, it has to be given after the delivery of the fetus, before the delivery of the placenta. That means within 1 minute of the delivery of the fetus, you have to give injection uterotonic to the mother. And WHO says that the injection injection uterotonic of choice is injection oxytocin, which you have to give 10 international units, IM or by IV infusion. All of you know that oxytocin should not be given as IV bolus because it can lead to hypotension and cardiac arrest, right? Second step is that you have to do a delayed cord clamping. Delayed cord clamping means when you clamp the cord within 1 to 3 minutes. So if you are clamping the cord at less than 1 minute, that is early cord clamping. And if you are clamping it within 1 to 3 minutes, then that is delayed cord clamping. So delayed cord clamping is a part of active management of third stage of labor. The third step is you have to deliver the placenta by controlled cord traction, and that is also called as modified Brand-Andrews technique. And the fourth step is intermittent assessment of uterine tone. Please remember that earlier, there was, the fourth step was not intermittent assessment of uterine tone, and earlier it was uterine massage, right? So uterine massage, earlier it was a part of active management of third stage of labor, but now it is not a part. But please remember that active management of third stage of labor never had early cord clamping. So early cord clamping is never a part of active management of third stage of labor, right? So I have told you 4 which are components of active management of third stage of labor. 1 which was earlier a part but it is now not a part, and 1 which is never a part of active management of third stage of labor. Now, out of the 4 components, if someone asks you which one is the most important component of active management of third stage of labor, then please remember that the first step, that is injection uterotonic after the delivery of the fetus, is the most important component of active management of third stage of labor. So with this background, this is question number 2. With this background, I want all of you to see question number 2, format 1. They are saying which of the following is a part of active management of third stage of labor. Uterotonic after the delivery of the placenta, is it a part? No. Controlled cord traction? Yes. Uterine massage, now it is not a part. Earlier it was a part, right? So it is in plus minus status. Early cord clamping, it was never a part. So if the question came in this format, then the answer was controlled cord traction. But if your question was which of the following is not a part of active management of third stage of labor, now let us see the options. Injection uterotonic, yes, it is a part. Early cord clamping, never a part. Controlled cord traction, yes. Uterine massage, plus minus status, earlier it was a part, now it is not a part. Right? So now your answer will become early cord clamping, because early cord clamping is never a part of active management of third stage of labor. Delayed cord clamping is a part of active management of third stage of labor. Are both the formats clear to you? Let's go to question number 3. Again, this was a very straightforward question. Which of the following complications is specific to monochorionic twins? Right? Now, when we are talking about complications of twin pregnancy, and that too about fetal complications, they can be divided into 3 categories. One are those set of complications which are in general common to twin pregnancy, irrespective of the fact whether the twins are monochorionic or whether the twins are dichorionic. Right? So overall in twin pregnancy, there is prematurity or there is preterm labor, and there are 50% chances of preterm labor in twin pregnancy, whether that is monochorionic or whether it is dichorionic. And number 2 is growth restriction. Now, when I see this growth restriction is in general to twins, and it is seen in both the twins, right? Please remember that 2 complications which will never be seen in twins will be post-term pregnancy, and macrosomia. So these are 2 complications which are never seen in twin pregnancy. So these are the complications, these 2 complications which I have told you just now, preterm labor, that is prematurity, and growth restriction, they are overall seen in all varieties of twins. Then there are certain set of complications which are seen only in monochorionic twins. As all of you know that monochorionic twins, they have a poor prognosis than dichorionic twins. So certain complications are seen only in monochorionic twins, and these complications are related to vascular complications, and these are number 1, twin-to-twin transfusion syndrome, number 2, TAPS, that is twin anemia polycythemia sequence, and number 3 is TRAP, twin reversed arterial perfusion, and number 4 is selective IUGR. Selective IUGR means only one fetus is having IUGR. This IUGR meant that both the fetuses were having IUGR. Selective IUGR is seen in monochorionic twins. Right? Then there are certain complications which are specific to monochorionic monoamniotic twins. And the complications which are specific to monoamniotic twins are cord entanglement, because in monochorionic monoamniotic twins, both the twins are lying in the same amniotic fluid. So the cords of the baby may get entangled, and that is why monoamniotic twins, monochorionic monoamniotic twins, you have to do a cesarean section between 32 to 34 weeks of pregnancy. And also one thing which you have to remember is that conjoined twins are complications of monoamniotic twins. Unless and until the twins are monoamniotic, they cannot become conjoined, right? So conjoined twins is also a complication of monoamniotic twins. Clear to all of you? Now, not only is the fetal risk increased in twin pregnancy, there are maternal risks also which are increased in twin pregnancy. And number 1, all the hemodynamic changes, they are more in mother in comparison, in a twin pregnancy in comparison to a single pregnancy, right? So because all the hemodynamic changes are more, there are increased chances of diabetes, there are increased chances of anemia. Apart from that, there are increased chances of preeclampsia. Why? Because in twin pregnancy, the size of the placenta is big. And all of you know that one of the reasons for preeclampsia is increased exposure to trophoblastic tissue. So that is why there are increased chances of preeclampsia. And when the size of the placenta would be big, it will lead to placenta previa, and there can be abruptio placenta. Then gestational diabetes, intrahepatic cholestasis, and acute fatty liver of pregnancy. All these things, definitely polyhydramnios. All these are complications of twin pregnancy, maternal complications of twin pregnancy. Anemia is going to be there, and that I've covered in hemodynamic changes, right? Okay. Now, so over here the question was, which of the following complications is specific to monochorionic twins? If they simply ask you growth restriction, is growth restriction specific to monochorionic? No, it is selective growth restriction which is, specific to monochorionic, not simply growth restriction. Polyhydramnios is not specific to monochorionic. Neural tube defects is not specific. What is specific is twin-to-twin transfusion syndrome. Right? Now, before I proceed to the next question, in monochorionic twins, there are complications. There were 2 types of complications which are happening. These first 4 complications which I have told you, these first 3 complications which I have told you over here, that is twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, and TRAP. They are because of abnormal vascular anastomosis which is happening in monochorionic twins. Whereas the selective IUGR which happens, it is because of unequal placental sharing. So I'll just tell you what is unequal placental sharing. So normally in monochorionic twins, there will be a single placenta and both the fetuses are going to do equal sharing of that placenta. Right? But suppose if one twin is getting less of the placenta and the other twin is getting more of the placenta. So obviously the twin which is getting more of the placenta, the blood flow to that twin will be more, and so the growth will be normal. Whereas if the twin which is getting less of the placenta, it is going to get less blood flow and its growth would be restricted, and that is how selective IUGR happens, because of unequal sharing of the placenta. Right? Now, in case of monochorionic twins, the twin-to-twin transfusion syndrome, TAPS and TRAP happens because of abnormal vascular connections between the twins. And how do you diagnose, twin-to-twin transfusion syndrome, TAPS and TRAP? See, twin-to-twin transfusion syndrome, I'm not telling you any details. I'm sure all of you know the details. Twin-to-twin transfusion syndrome, it happens because of the deep vascular anastomosis which is happening between the twins. And on ultrasound, you are going to get monochorionic diamniotic twins, and one of the twins will be having oligohydramnios and other twin will be having polyhydramnios. That is how you are going to diagnose twin-to-twin transfusion syndrome on ultrasound. it is a monochorionic diamniotic twins, one twin having oligo, other twin having poly. That means you are dealing with twin-to-twin transfusion syndrome. On the other hand, when I have to diagnose twin anemia polycythemia sequence, I will have to do a Doppler of the middle cerebral artery, and I will have to see the peak systolic velocity of the middle cerebral artery. In case of the anemic twin, the peak systolic velocity of the middle cerebral artery would be increased, and how much increased? It will be more than equal to 1.5 MOM. Whereas in case of the polycythemic twin, the PSV will be decreased, and how much decreased? Less than 0.8 MOM. So all of those who are wondering that where have I taught this in the Marrow videos, this is there in the Doppler studies. If you go to Marrow edition 5, you will see that I have included a chapter called as RH incompatibility and Doppler studies. In Doppler studies, you are going to get all the important Dopplers and the findings which you have to remember, right? Then comes TRAP. What is TRAP? That is twin reversed arterial perfusion. In TRAP, there is one twin which doesn't have a heart, and that is an acardiac twin. The other twin, which is normal, is going to pump blood to the twin which doesn't have heart, but it is going to give blood to the acardiac twin with the help of umbilical artery. Now, all of you know that normally in a fetus, the oxygenated blood comes to the fetus through umbilical vein. But over here, this acardiac twin is getting blood through the deoxygenated blood from umbilical artery of the donor twin, which is the normal twin, right? So that is why it is called as twin reversed arterial perfusion, because the acardiac twin is getting blood from the normal twin, but not through its umbilical vein, but through its umbilical artery. And umbilical artery, it carries deoxygenated blood. And that is why in this acardiac twin, all the parts of the body are not going to develop. Now, in acardiac twin, there can be two situations. Either the lower part of the body can be developed and the upper part is not developed. So, if lower part of the body is developed and upper part is not developed, such an acardiac twin is called as acardious acephalous. Or it could be that none of the body part is developed, and then it is called as acardious amorphous, right? So these two images or these two pictures, they can come as spotters to you, right? So this was about the monochorionic twins. Then comes question number 4. Instruments used in cesarean section are. Now, I want all of you that you should watch a video which I have given in the Marrow YouTube channel, and that is Instrument in Obs and Gynae. In Instruments in Obs and Gynae, I have dealt in detail with all the important instruments which you have to know for your any exam. That could be your final year exam, or that could be your NEET exam, or INI CET exam, or FMG exam for that matter. So over here, the option given were Alice forceps. Now, I am not going to tell you in detail, but in the video, I have told you in detail. Basically, what is Alice forceps used? Alice forceps is used for holding any tough structure, right? So when you are doing cesarean section and you have to hold rectus sheath, while opening and while closing the abdomen, you are going to use Alice forceps. Alice forceps, it is a forceps which has got toothed end. So it's of, the proximal end is curved and there are 4 or 5 teeth which are present there, right? So Alice forceps, definitely it is used in cesarean section. And for what purpose? It is used for holding non-bulky tough structures like rectus sheath. Now, the next instrument is a green armitage. Now, in the video also, I have told you green armitage is an instrument which has got a triangular flat end. Now, can you see over here a triangular flat end, right? And this triangular flat end, it has got transverse serrations, right? So this is a non-traumatic instrument and it is hemostatic also. So with this green armitage, you are going to hold the angles of the uterus while you are, closing the uterus. So when you have to close the uterus and you want to hold the angles of the uterus, you are going to use green armitage. Please remember that to hold the angles of the uterus for a uterine incision, you can also use Alice forceps for that particular purpose, but that's not the best one. The best one is to use a green armitage, right? So over here, I have also shown you image of green armitage holding the angles of the uterus. So this is used for holding green armitage. It is used for holding the angles of the uterus while you are, closing the uterus. Then comes retractors. Now, retractors, there are two purposes of retractors. One, you can use retractors to retract the skin and the tissues after you've given the incision. The other one is you can use the retractors to hold the organs away so that your field of vision is clear, right? So, in case of cesarean section, I'm going to use a retractor to retract the abdominal wall and to retract the bladder. And that retractor which we use is a Doyen's retractor. This Doyen's retractor, as you can see, it has got a broad front end and its front end is curved. So the proximal end of the Doyen's retractor is curved, and with the help of Doyen's retractor, I am going to retract the bladder during the cesarean section. It is a non-self-retraining retractor, right? Now, if I want to retract the abdominal wall while I'm doing abdominal surgeries, then the better retractor is a Morris retractor. A Morris retractor is also a broad retractor. Its proximal end or the blade is broad, but the difference is, number one, it is not curved, it's flat. Right, that is how you're going to differentiate it from Doyen's retractor. And number two, it is at an angle of 90 degrees. Right, so the blade is at an angle of 90 degrees from the handle. And this Morris retractor is used to retract the abdominal wall in abdominal surgeries. Now, while I am suturing the rectus sheath, and I want to retract the skin, then the retractor which I'm going to use will be a Zerni's retractor. In a Zerni's retractor, it's a Z-shaped or a Z-shaped retractor where the two ends are, at one end, there will be two prongs, and at the other end there will be a solid blade. So you can see over here at one end there are two prongs, and at the other end there is a solid blade, and both these are at 90 degrees to the handle, right? So Z for Zerni's and Z for the shape of the instrument. And Zerni's retractor is used to retract the skin or, the tissues while you are closing the abdomen or while you are opening the abdomen. Then comes sponge holding forceps. Sponge holding forceps, all of you can recognize this sponge holding forceps. Again, it will have a ratchet lock and it will have ring shaped ends, and in those rings, serrations will be present like this, right? So a sponge holding forceps, it is used for painting and draping of the parts before surgery, and you can also use it to apply pressure with a swab during pelvic surgery, and you can use it to hold the lips of a pregnant cervix, right? And also you can use it to hold the edges of the uterus in LSCS. So if I want to hold the edges of the uterus in LSCS, the most specific kind of instrument is green armitage. But if I do not have green armitage, I can use a sponge holding forceps or I can use an Alice forceps, right? Then a Cusco's speculum. Please remember that a Cusco's speculum is a self-retaining speculum and it is used to retract the anterior and the posterior wall of vagina. And basically it will be used when you are doing a per speculum examination or when you are doing OPD procedures vaginally, like a pap smear, IUCD insertion, or when you are taking endometrial biopsy or cervical biopsy. It doesn't have any role in cesarean section. Then comes Shirotkar's uterine holding clamp. Now this, as the name suggests, this is a clamp and it is used to hold the uterus. So when you have to manipulate the uterus during surgeries like sling surgeries, then over here you are going to hold the isthmus of the uterus. So over here in a Shirotkar's uterine clamp, you will see that the front end is curved. Right, so there is a curved front end, and in this curved front end, there is a gap, and in that gap, the isthmus of the uterus will be held. So if I want to manipulate the uterus, then I'm going to use, during, surgeries like sling surgeries, I'm going to use a Shirotkar's uterine holding clamp, and it will have no role in cesarean section. In this question, instruments used in cesarean section, Alice forceps, yes. Shirotkar clamp, no. Doyen's retractor, yes. Cusco's speculum, no. Bard Parker handles, BP handle and blade. Without a BP handle and blade, you cannot give an incision, so you have to use it. Green Armitage, yes. So these are the instruments which are used in cesarean section. Next time, they may even ask you instruments which are used for DNC and instruments which are used for hysterectomy. So all this will be clear to you once you watch the video on instruments in Obs and Gynae, which is there for free for all of you to watch on the Marrow's YouTube live video. Question number 5. What is the normal uterocervical length? Now, again, this question I have taught to you in that particular video, that is the instruments in Obs and Gynae. Now, please remember that the normal uterocervical length, it is between 6 to 8 centimeters. In inches, it is 2.5 inches. And this is what is seen in a nulli-gravida female. In a multi-gravida female, it is 9 to 10 centimeters. And if I want to measure the uterocervical length, I'm going to do it with an instrument which is called as a uterine sound. Now, if you look at a uterine sound, in a uterine sound, what you're going to see that this instrument, it has got a curve. Can you see over here? This is a straight instrument like this, and it has a gentle curve, right? And its tip is olive tipped, right? So it is an olive tipped end, and it has got serrations. So this is how a uterine sound looks like, and you will have to know that how to differentiate a uterine sound from a bladder sound. So before I perform any open, procedure like suppose dilatation and curettage or IUCD insertion, I should know the length of the uterocervical length, and for that purpose, I'm going to use a uterine sound, right? Then the other things which you should know is that why is it olive tipped? It is olive tipped so that perforation doesn't happen. But by chance you were introducing the uterine sound and perforation did happen. Then what are you going to do? So if perforation happened with a uterine sound, please do not worry because it will be a small perforation. You just have to stop the procedure immediately and you have to wait and watch. Right? The other things which I want you to know are in what conditions are uterocervical length increased. So when will be the uterocervical length increased? It will be increased if you have perforated the uterus, right? So in that case, you are going to get that the uterocervical length is coming out to be increased. Apart from that, if there is supravaginal elongation of the cervix, which is going to happen in case of uterocervical prolapse, or if there is congenital elongation of the cervix and in pregnant females. So in all these conditions, uterocervical length is increased, right? Then in which conditions is the uterocervical length decreased? All of you know that cervix and uterus, both of them atrophy after menopause. So uterocervical length is going to decrease after menopause. Or if there is congenital hypoplastic uterus, or if you've done amputation of the cervix like you do it in Fothergill's repair, or in case of chronic inversion, or if you've done a subtotal hysterectomy. In a subtotal hysterectomy, you remove the cervix and you remove the uterus and not the cervix. So definitely the uterocervical length would be decreased, right? So these are all the questions which can be asked on uterocervical length in future. Coming to question number 6, again a very, very simple question. Fixative which is used in pap smear. Question 6 and question 7 we are going to deal together. And question 7 was a straightforward question where they had shown you these two instruments and they had asked you, they had shown you these two instruments. And they had asked you in which, for which procedure they are used. So all of you know that this is an Ayer's spatula and this is an endocervical brush. This over here is a cervical brush or a cervical broom. Cervical brush or a cervical broom which is used for liquid-based cytology, right? So over here, this we have Ayer's spatula and this is the endocervical brush. Now, with the help of Ayer's spatula, I'm going to take sample from the transformation zone. I'm going to place the bifid end of the Ayer's spatula on the external os and I'm going to rotate it by 360 degrees for 2 to 3 times, and whatever smear comes, I'm going to put it on a slide. Please remember that before you do pap smear, you should never do a pervaginal examination. You should never apply a lubricant, and you should also advise the female that at least there has to be 24 hours of abstinence when you are doing a pap smear. So for 24 hours, there shouldn't have been any intercourse, right? One of the relative contraindications for doing pap smear is bleeding. And the best time for doing pap smear, it is in the peri-ovulatory phase, because at that time the cervical mucus is going to be the maximum, right? So with the help of Ayer's spatula, you're going to take sample from the transformation zone or from the external os, and with the help of this endocervical brush, you are going to take sample from the endocervix. Both these samples, you have to put it on the same slide. You do not have to air dry the slide, and you are going to use a fixative. The fixative which you are going to use will be 95% ethyl alcohol plus minus 5% ether. These days, laboratories are not keeping ether because it is highly inflammable, right? So, your question, a fixative used in pap smear, question number 6, answer is 95% ethyl alcohol. Right? Now, as far as screening for cancer cervix is concerned, please remember that screening for cancer cervix is going to begin by 21 years of age, and the method is pap smear. You have to do a pap smear every 3 yearly till the female reaches 30 years of age. Now, once she reaches 30 years of age, you are going to do pap smear plus HPV DNA testing. When you do pap smear and HPV DNA testing, that is what is called as a co-test, and this should be done every 5 years. Now, if a female says that she cannot afford HPV DNA testing, then after 30 years also, I have to keep on doing pap smear. And if you are doing only pap smear, you are going to repeat it after every 3 years. Until when are you going to do pap smear? You're going to do pap smear till a female is 65 years of age, but there is one condition which should be fulfilled. And the condition is that in the past decade, so in the past 10 years, her screening should have been normal. Now, if in the past 10 years, the screening was not normal, then in that case, the age at which you're going to stop pap smear is, or you're going to stop screening is 75 years of age. Now, suppose if there is a female who has undergone hysterectomy for a benign cause, like for example, fibroid or prolapse, then in that case, you can stop screening after these procedures. But if there is a female who's undergone hysterectomy because of a malignant cause, like cancer cervix or cancer endometrium, then you have to continue screening till 25 years after the surgery, right? Please remember that pap smear is the most specific method for screening, whereas HPV DNA is the most sensitive method for screening. And the most cost-effective method for screening is visual inspection with acetic acid. Just one more thing which I want to tell you. See, when you are doing this HPV DNA testing, this is just going to tell you that yes, high-risk HPV is present or not. It is not going to tell you the subtype of HPV which is present. So, if you want to know the subtype of HPV which is present, then the test which you do is a COBAS test or a BD on clarity test, right? So this is if you want to know the subtype of HPV DNA. Coming to question number 7, again a very, very easy question. Which of the following are not included in quadruple test? Inhibin B, alpha-fetoprotein, HCG, and unconjugated estriol. So all of you know that inhibin B is not included in quadruple test. It is inhibin A which is included in quadruple test. So when we are talking about the aneuploidy screening, or when we are talking about Down syndrome screening, in the first trimester, I have a biochemical test which is called as the dual test. In dual test, I'm going to look at the values of PA, PPA and HCG. And you can also go for ultrasound, and in ultrasound, I'm going to look at the nuchal translucency, right? In case of Down syndrome, H for HCG, H for high, rest all biochemical markers are decreased. So PA, PPA would be decreased. See, normally when you do a screening, either you do a biochemical screening or you go for ultrasound. But if you are doing both 1 and 2, that means you are doing biochemical and you are doing ultrasound in the first trimester, it is called as a combined test, right? Then comes second trimester screening. In second trimester screening, the best one which we do is a quadruple test. In quadruple test, you're going to look at the values of HCG, alpha-fetoprotein, unconjugated estrogen, that is unconjugated estriol, E3, and inhibin A. This is what is called as a quadruple test. Generally, a quadruple test should be done between 15 weeks to 18 weeks, but it can be done up till 22 weeks plus 6 days. Right? And fourth is you can also go for ultrasound, and on ultrasound I'm going the second trimester, I'm going to look at the soft tissue markers. 2 or more than 2 soft tissue markers should be present to say that yes, the screening is positive for Down syndrome. Please remember there is something called as a fully integrated screening. A full integrated screening includes first trimester biochemical test, that is dual test, plus nuchal translucency plus quadruple test. So if you are including 3 tests, dual test, nuchal translucency, and you are including quadruple test, that is called as a full integrated test. Whereas a serum integrated test means that you are doing a dual test and you are doing a quadruple test. So if someone asks you which is the best or the most sensitive for Down syndrome, the most sensitive will be fully integrated screening. If fully integrated screening is not given in the options, then a serum integrated test is also good enough. Now, in case of Down syndrome, alpha-fetoprotein levels are decreased, unconjugated estrogen is decreased, H for HCG, H for high, so HCG is high, and I for inhibin, I for increased. So inhibin A levels are increased. Whereas in case of trisomy 18, HCG levels are also decreased. So alpha-fetoprotein is decreased, unconjugated estrogen is decreased, HCG is decreased, inhibin A is unchanged. And in case of trisomy 13, HCG is decreased, rest all are unchanged, right? Now, one very common mistake which you think is that when you get a report of Down syndrome, or suppose when you get a report of quadruple test, the report will never say that the test is positive or the test is negative. The report is simply going to give you a ratio, and from that ratio you have to interpret whether this female patient which you have, the pregnant patient, whether she is at high risk for Down syndrome or whether she is at low risk for Down syndrome, right? So for quadruple test for Down syndrome, the cutoff ratio is 1 in 250, which means that if I did this test in a pregnant female and her result came as 1 in 500, so 1 in 500 is less than 1 in 250. Because cutoff is 1 in 250 and 1 in 500 is less than that, so I know that my patient is having less risk of Down syndrome, and so I am not going to do any further testing. But on the other hand, suppose the report came as 1 in 50. Now, 1 in 50 is much more than 1 in 250. That means now my patient has high chances of having Down syndrome or aneuploidy, and then I have to do a confirmatory test. Now, straight away you can either go to a confirmatory test, and confirmatory test is karyotyping, or you can do a secondary screening test, and the secondary screening test is cell-free fetal DNA. Please remember that cell-free fetal DNA is a secondary screening test. It is not a diagnostic test. If cell-free fetal DNA comes out to be positive, you again have to go to the definitive test, the confirmatory test, and that is karyotyping. Clear to all of you? So next time they may give you a question where they are giving you a quadruple test, the values, and they give you a ratio and they ask you to interpret the result, and this is how you have to interpret the result. Clear to all of you? Coming to question number 8, which is, an integration between microbiology and OBGY. HPV viral gene oncoprotein which inhibits retinoblastoma gene. So all of you know that in HPV we have early genes. The genome has got early genes and it has got late genes. In early genes there are E1 and E2. E1 and E2 are responsible for viral replication, whereas E6 and E7 are the ones which are responsible for oncogenic potential of HPV. Between E6 and E7, E6 is the one which is going to knock out the tumor suppressor gene P53, whereas E7 is going to be the one which is going to take out, the final step of oncogenesis. That's the final step, and that is it is going to knock out the retinoblastoma gene. So it is the E7 gene which knocks out the retinoblastoma gene. Apart from these early genes, in HPV viral genome, there are late genes also present, in which L1 and L2 are the major ones, and between L1 and L2, the major one is L1, and it is this L1 gene or the L1 capsid protein from which the HPV vaccines are made. right? So HPV vaccines are made from L1 capsid proteins, and these two, both L1 and L2, are present in the capsule. Coming to question number 9, again, that's a very straightforward question. According to WHO 2010, lower reference value for normal semen morphology should be. So, this is a very straightforward question. All of you, I have repeatedly told you that you have to remember the WHO parameters for semen analysis, and I have also told you that these WHO parameters for semen analysis, they are not telling you the average values. They are telling you the minimum required for conception, right? So minimum this much is required for conception. That is what they are telling you. They are not telling you the average values, right? So, sperm volume, it should be more than equal to 1.5, pH more than 7.2, total sperm count should be more than equal to 39 million per ejaculate, sperm concentration 15 million per ml, total motility should be 40%, amongst which 32% should be progressive or forward motility. Morphology, as per the strict Tiger-Burke criteria, it should be 4%. Vitality should be 58%, right? So, the answer to this question is 4%, right? Now, the other things which I want you to remember are, in which condition do you see asthenospermia, decreased motility? So one of the very important conditions in which you see asthenospermia is cartilaginous syndrome. And in which conditions do you see azoospermia? What do you understand by azoospermia? Azoospermia means there is no sperm in semen. That is what is meant by azoospermia. Aspermia means no semen. Azoospermia means no sperms in semen. So there are two very important conditions in which you have to remember that azoospermia happens, and one of them is cystic fibrosis, others is Klinefelter syndrome. The other important question which they can ask you is that what is the average sperm count? Please remember, if they ask you the sperm count as per the WHO parameter, then it is 39 million per ejaculate. That means this is minimum 39 million per ejaculate is needed for conception. But this is not the average value. If they ask you what is the average sperm count is 60 to 100 million per ejaculate. And amongst all the criteria, amongst all the parameters of semen analysis, which one is the most important parameter? The most important parameter for conception is sperm morphology, then it is motility, and then concentration. Please do not go by what others are saying. What I am telling you, you have to remember that, specifically the marrow users. Right? So on marrow links, you always ask me this question, and with reference, I have told you that the answer to this question is sperm morphology. If sperm morphology is not given, then sperm motility, and if that is also not given, then sperm concentration. Right? Of just a few pointers about male infertility, see the semen analysis, that's the first investigation which you do whenever a couple comes to you, and there are certain instructions which you have to give as per the semen analysis. So you have to tell them that there has to be a compulsory abstinence for minimum 2 days and maximum 7 days. The best way to collect the sample is by masturbation. Samples should reach the lab within 1 hour, and analysis should be done on liquefied semen. Liquefaction time is 30 minutes. Fertilizable span of sperm is 72 hours, and spermatogenesis takes 72 days. So approximately the range is 70 to 74 days, and that is how you're going to remember that the time for spermatogenesis is 72 days and the fertilizable span of sperm is 72 hours, right? Okay. Coming to question number 10, which is, an integrated question between physiology and between OBGY. Which of the following is structurally and functionally similar to HCG? So many times we've done this, that HCG has got alpha and beta subunits. Its alpha subunit is structurally similar to LH, FSH and TSH. So LH, FSH and TSH. So alpha subunit is same in all of them. But it is the beta subunit which is very specific. But here they are not asking you structurally. They are asking you structurally and functionally. Functionally, HCG is similar only to LH. How? It is HCG which helps to maintain corpus luteum in pregnancy, whereas LH helps to maintain corpus luteum in a non-pregnant female, right? So that is how HCG and LH are functionally the same. Question number 11, that brings us to gynae questions. And the first question which is asked in the amenorrhea and disorders of sexual development series, match the following conditions with their respective karyotype. So MRKH syndrome. What is MRKH syndrome? It is Mayer-Rokitansky-Kuster-Hauser syndrome. And in Mayer-Rokitansky-Kuster-Hauser syndrome, there is Mullerian agenesis, right? So this is a condition where you are going to get Mullerian agenesis. So MRKH is a condition in which you get Mullerian agenesis, right? And in Mullerian agenesis, all of you know that the karyotype is absolutely normal. They are 46XX. Then you have Swyer syndrome. Swyer syndrome is 46XY. It is a type of gonadal dysgenesis. Gonadal dysgenesis is of three types. Number one, Turner syndrome, 45XO. Number two, it can be pure gonadal dysgenesis where you have 46XX lineage. And number three, it can be Swyer syndrome, which is 46XY, right? Then androgen insensitivity syndrome. In androgen insensitivity syndrome also there is 46XY, and then you have Turner syndrome, which is 46XO. All these are causes of primary amenorrhea, right? The most common cause of primary amenorrhea, if they ask you, the best answer will be gonadal dysgenesis. If gonadal dysgenesis is not given, then you are going to say Turner syndrome. If gonadal dysgenesis is given, you're going to mark it as gonadal dysgenesis because gonadal dysgenesis includes Turner syndrome, Swyer syndrome, and pure gonadal dysgenesis, right? This is the most common cause for primary amenorrhea. The second most common cause for primary amenorrhea is MRKH syndrome. MRKH syndrome, right? Now, if they ask you what is the best investigation in case of primary amenorrhea, the best investigation in case of primary amenorrhea is undoubtedly karyotyping. But suppose if they say that there is a female who comes to you with primary amenorrhea and they ask you that what is the next step in investigation, the next step in management. So the next step is not karyotyping. Whenever a female comes to you with primary amenorrhea and they ask you what is the next step in investigation, you are not going to immediately jump to karyotyping. You are going to say that the next step in investigation, number one, will be urine pregnancy test. Please remember that in primary amenorrhea also you should do a urine pregnancy test, especially if the secondary sexual characteristics are well developed, right? Then you are going to do an ultrasound because with the help of ultrasound, I'm going to know whether uterus is present or not, right? So the next step will be urine pregnancy test and then you can go for ultrasound. Urine pregnancy test, you're going to do only if secondary sexual characteristics are present. Then you're going to go for an ultrasound and then you are going to go for LH-FSH levels. Right? So, and then last is that, yes, the best investigation is karyotyping. So, this is the sequence which you have to follow whenever a patient comes to you with primary amenorrhea. You have to do an ultrasound, you have to do LH-FSH levels, and then, yes, the best one is you're going to go for karyotyping. Right? The other thing which I want to point out over here is that all of you on the Marolin group, you keep asking me that, ma'am, how to differentiate between androgen insensitivity syndrome and Swyer syndrome. Both of them have got 46XY. So let us quickly see how you can differentiate between androgen insensitivity syndrome and Swyer syndrome. See, in both of them, the karyotype is 46XY, and because karyotype is XY, because Y chromosome is present, so in both of them, the gonads are going to be testes, right? Now, the problem is that in androgen insensitivity syndrome, these testes are functioning normally. But the problem is that these individuals, they are insensitive to testosterone. So, they are resistant to testosterone. But the testes function normally in androgen insensitivity syndrome. On the other hand, in case of Swyer's syndrome, the testes are not functioning. They are dysgenetic gonads. Dysgenetic testes. So, in case of Swyer's syndrome, the testes are there, but they are not functioning. Clear to all of you? Now, all of you know that testes have got Sertoli cells, and from Sertoli cells, inhibin is released, and from Sertoli cells, in the intrauterine life, Mullerian inhibiting substance is released. right? And this Mullerian inhibiting substance is also called as anti-Mullerian hormone. So in case of androgen insensitivity syndrome, because testes are functioning normally, so Sertoli cells will normally release the Mullerian inhibiting substance, and so Mullerian duct is going to regress. And because Mullerian duct is going to regress in androgen insensitivity syndrome, uterus is going to be absent, right? But on the other hand, in Swyer's syndrome, the testes are not functioning. They are dysgenetic. So if testes are not functioning, Sertoli cells will not produce Mullerian inhibiting substance. And so if Mullerian inhibiting substance is not produced, so Mullerian duct is going to grow. And because Mullerian duct is going to grow, in Swyer's syndrome, uterus will be present. So have you got your first difference over here? In androgen insensitivity syndrome, uterus is absent, whereas in Swyer's syndrome, uterus is present, right? Now, Leydig cells are the ones which produce testosterone, and testosterone, they get converted into dihydrotestosterone. And all of you know that it is testosterone which leads to the formation or leads to the development of Wolffian duct in males. Now, in case of androgen insensitivity syndrome, the testes are functioning normally, so Leydig cells will produce testosterone, but these individuals are insensitive to testosterone, and they are insensitive to dihydrotestosterone. Please remember that testosterone and dihydrotestosterone, they act through the same receptor, right? So if they are insensitive to testosterone, they have to be insensitive to dihydrotestosterone also. Now, because in androgen insensitivity syndrome, they are insensitive to testosterone, so Wolffian duct is going to regress. And because Wolffian duct is regress, male internal genital organs will not be formed. It is Wolffian duct which is responsible for formation of male internal genital organs like seminal vesicles, epididymis, ejaculatory duct, and vas deferens. So in androgen insensitivity syndrome, we have a male who has neither Mullerian duct nor Wolffian duct, right? And because testosterone and dihydrotestosterone are acting from the same receptor, and it is dihydrotestosterone which leads to the formation of male external genitalia. Please remember that in all fetuses, in intrauterine life, they have a natural tendency, the external genitalia have a natural tendency to form female external genitalia, right? Only and only if dihydrotestosterone is present, then it is that the external genitalia look like male. If dihydrotestosterone is absent, then the external genitalia will look like female external genitalia. And this is what happens in androgen insensitivity syndrome. Because they are insensitive to testosterone and dihydrotestosterone, so their external genitalia looks like female. And that is why at the time of birth, they are taken up as a female child. Let's see what happens in Swyer's syndrome. In Swyer's syndrome, Leydig cells are not going to function. And because Leydig cells are not going to function, so testosterone will be absent. Because testosterone will be absent, so Wolffian duct will regress. So over here also there will be no male internal genital organs, and here also external genitalia will look like female, because if there is no testosterone, then there is no dihydrotestosterone. So both these conditions, they are 46XY, but their external genitalia resemble female. So both of them, they are taken as a female child at the time of birth. And in both of them, because external genitalia are female-like, that is why testes will remain undescended and they can present to you as a case of inguinal hernia, right? Now, because both these are taken as a female child, but they are not females. They do not. The one is 46, both of them are 46XY. And in case of androgen insensitivity syndrome, there is no uterus. In Swyer's syndrome, uterus is present, but ovary is not present. So obviously, both of them are not going to menstruate once they reach puberty. And both these cases are going to present to you as a case of primary amenorrhea, right? Now, at the time of puberty, in androgen insensitivity syndrome, testosterone is present still, but they are resistant to testosterone, right? So because testosterone is present, that is, and they are resistant to testosterone. So that is why no male secondary sexual characteristics will develop, right? And because they are resistant to testosterone, so there won't be any pubic hair and axillary hair. All of you know that for development of pubic hair and axillary hair, you need testosterone. But because testosterone is present, this entire testosterone will get converted into estrogen, and they are sensitive to estrogen. Because they are sensitive to estrogen, so there will be proper breast development. So in androgen insensitivity syndrome, there will be proper breast development. But what about in Swires syndrome? In Swires syndrome, the testes are dysgenetic. There is no testosterone. If there is no testosterone, there will be no male secondary sexual characteristics. There will be no pubic hair, no axillary hair, and there won't be any breast development also. Right? So you've got your other difference. In androgen insensitivity syndrome, uterus was absent, breast is present. In Swires syndrome, uterus is present, breast is absent. Right? What about testosterone levels? In androgen insensitivity syndrome, the levels of testosterone will be high as compared to a female. Whereas in Swires syndrome, the levels of testosterone would be low. What about inhibin? I told you Sertoli cells, they secrete inhibin, right? So in androgen insensitivity syndrome, testes are functional. So inhibin levels will be normal in androgen insensitivity syndrome. Whereas in Swires syndrome, Sertoli cells are dysgenetic, the testes are dysgenetic. So inhibin levels would be decreased, right? Now, because in androgen insensitivity syndrome, inhibin levels are normal, and inhibin, all of you know, has a negative feedback on FSH. So FSH levels will be normal. Because in Swires syndrome, inhibin is decreased, so the negative feedback on FSH will not be there. So in Swires syndrome, FSH would be increased. What about LH? LH is basically controlled by testosterone. In androgen insensitivity syndrome, testosterone is present, but they are resistant to testosterone, right? So the negative feedback on LH is gone. So the levels of LH will be increased in androgen insensitivity syndrome also, and in Swires syndrome also, right? In androgen insensitivity syndrome, FSH is normal, but in Swires syndrome, FSH is high, right? So just in case you did not understand this while I was explaining to you, later on this video will be available on YouTube. You are just going to watch this video again. Androgen insensitivity syndrome and Swires syndrome, these are the differences between them, right? Coming to question number 12. Which of the following is not a cause of secondary amenorrhea? Option A, Sheehan syndrome. Option B, Asherman syndrome. Option C, Turner syndrome. And option D, Kalman syndrome. So all of you know that what is secondary amenorrhea? Secondary amenorrhea means in a previously menstruating female, if there is absent menstruation equivalent to 3 cycles, right? So if there has been no menstruation equivalent to 3 cycles, or no menstruation for a period of 6 months, then that is what is called as secondary amenorrhea. The most common cause of secondary amenorrhea is pregnancy. So in all patients of secondary amenorrhea, you have to do a urine pregnancy test and you have to rule out pregnancy. Apart from that, you also have to do TSH levels and prolactin levels, right? The important causes of secondary amenorrhea, if we start from the uterus level, in the uterus, the defect which can lead to secondary amenorrhea is Asherman syndrome, where adhesions are present inside the uterus and the endometrium is defective. When we go to the ovary level, the reason which can lead to secondary amenorrhea related to ovary is PCOS and premature ovarian failure. That means ovarian failure which is happening in less than 40 years. Then if we talk about pituitary, so in pituitary, if there is necrosis of the anterior pituitary gland, that is Sheehan syndrome, that can lead to secondary amenorrhea. Or if there is a prolactinoma, if the levels of prolactin are high, there is a microadenoma or a macroadenoma leading to prolactin secretion. Prolactin, it has got a negative feedback on GnRH, and because prolactin has a negative feedback on GnRH, so the levels of LH and FSH are going to decrease, and obviously that is going to lead to secondary amenorrhea. And a hypothalamic cause which can lead to secondary amenorrhea is excessive exercising, excessive dieting, that is anorexia nervosa or bulimia nervosa. So over here you can see that yes, Sheehan syndrome is a cause of secondary amenorrhea. Asherman syndrome is a cause of secondary amenorrhea. Kalman syndrome and Turner syndrome are causes of primary amenorrhea. Kalman syndrome is hypothalamic failure. So there is hypothalamic failure. There is decreased GnRH in Kalman syndrome, plus there is anosmia, right? Now, between Turner syndrome and Kalman syndrome, if I have to choose one of them, that one of them may lead to secondary amenorrhea, that is Turner syndrome. Please remember that in Turner syndrome, there can be 3 karyotypes. The most common karyotype definitely is 45XO. And when the karyotype is 45XO, they are going to present to you as a case of primary amenorrhea, and they will always be short-statured. And all the clinical features which we discuss in Turner syndrome, webbing of neck, cubitus valgus, shield-shaped chest, all of them will be seen in Turner syndrome with the karyotype 45XO. But they can be a mosaic in Turner's also. Mosaics, they can be 45XO and 46XY or 45XO with 46XX, right? Now, if there is a Y chromosome present in the mosaic, then that whenever Y chromosome is present, there are increased chances of cancer. And which cancer? There are increased chances of gonadoblastoma, right? Now, if there is a mosaic with XX cell line, right? So if there is 45XO and 46XX, these individuals, their ovaries may contain functional ovarian cortical tissue, and because they have functional ovarian tissue, they may present to you as a case of secondary amenorrhea, right? So initially some cortex, some ovarian tissue was functional, and because some ovarian tissue was functional, some follicles were present, and those some follicles, they led to menstruation or menarche. And later on, when those follicles are used up, then this female will come to you as a case of secondary amenorrhea. In such females, some degree of breast development may be present. There is a possibility of pregnancy also, and they may have a normal height also. So in Turners who are mosaic, it is not necessary that they will be short stature. It is not necessary that they present to you as a case of primary amenorrhea. They may present to you as a case of secondary amenorrhea, and they may be normal height as well. Please remember that even though the diagnosis of Turner syndrome is a very, very clinical diagnosis, by looking at the clinical features, by the short height and by absent secondary sexual characteristics, we definitely come to know that we are dealing with a case of Turner syndrome. But still in Turner syndrome, a karyotyping should always be done, because it could be that this Turner syndrome is a mosaic and has got Y cell line, and whenever Y cell line is present, there are increased chances of cancer. Otherwise, in Turner syndrome, if it is 45XO, the chances of malignancy are not there. But if Y chromosome is present, then the chances of malignancy, and that too gonadoblastoma, is there. So always karyotyping should be done in patients of Turner's syndrome. Clear? Coming to question number 13. Question number 13 is, an 18-year-old girl presented with amenorrhea. On examination, she had normal genitalia and normal breast development. Her tests revealed 5-alpha reductase deficiency. What could be the probable diagnosis? Right, so over here the options are concealed sex, true hermaphroditism, female pseudo-hermaphroditism, and male pseudo-hermaphroditism. So this is a question which has come from disorders of sexual development. These days we do not use terms like hermaphroditism, we use terms like disorders of sexual development. All these come under disorders of sexual development. Right? Now, before I tell you the answer to that question, just a few basic concepts. See, when we are talking about the genetic sex or the genotype, right? So all of you know that as per genotype, how do we know that we are dealing with male or female? Genotype, say we can come to know that we are dealing with male or female is based on the presence or the absence of Y chromosome. See, SRY gene, which is sex-related gene, it is present on the short arm of Y chromosome, on the distal end, right? So it is present on the distal end of the short arm of Y chromosome. So if SRY gene is present, in other words, if Y chromosome is present, then we say that the the sex of the baby is male. And if Y chromosome is absent, then we say that the sex of the baby is female. Right? So it is as simple as that. Y chromosome present, male as per genotype, and Y chromosome absent, female as per genotype. So if it is 46XO, the genotype is 46XO. So as per genotype, they are females because Y chromosome is absent. Similarly, if we are talking about Klinefelter syndrome, 47XXY, because Y chromosome is present, so as per genotype, they are males even though two X chromosomes are present. Right? That is how the sex is decided based on karyotype or based on genotype. Then comes gonads. How do the gonads develop? See, if Y chromosome is present, in other words, SRY gene is present, then the gonads which are going to be formed will always be testes. Right? Then the gonads formed will be testes. Now, if Y chromosome is absent, in other words, if SRY gene is absent, then the gonads which will be formed will be ovaries. So, for development of ovaries, you need absence of Y chromosome, right? For testes, you need presence of SRY gene, and there is one more gene which is a testes determining gene, and that is SOX9 gene. This gene also plays role in testes differentiation apart from SRY gene, right? So please remember that although for formation of ovaries, whether ovaries will be present or not, it depends on the Y chromosome. If Y chromosome is absent, then only gonads will be ovaries. But for proper development of ovaries, both X chromosomes are needed. And that is why in Turner syndrome, which is 45XO, the gonads are ovaries, but because both X chromosomes are not present, they are dysgenetic gonads. Now, how is the internal genitalia decided? Just now I told you how internal genitalia is decided, that in testes, Sertoli cells is present, which will secrete Mullerian inhibiting substance, right? So Mullerian duct is going to regress in males, and testosterone will be released by Leydig cells, and it is this testosterone which leads to the development of Wolffian duct, and it is Wolffian duct which forms male internal genital organs, and it is this testosterone which gets converted into dihydrotestosterone with the help of enzyme 5-alpha reductase, and that is how external genitalia look like, male external genitalia. And in absence of dihydrotestosterone, the natural tendency of the external genitalia is to look like female. So if dihydrotestosterone is absent, or if 5-alpha reductase is absent, then in that case, in males also the genitalia will be like females, right? And this is the opposite of this happens in females. In females, because testosterone is absent, so Wolffian duct will regress. Because dihydrotestosterone is absent, so external genitalia will look like female external genitalia. This much is clear to you? So this over here, this all what I have told you is normal sexual development. If there is an abnormality in any of these, if the karyotype or the gonads or the internal genitalia or the external genitalia, there is a mismatch in any one of them, right? That is what is called as disorder of sexual development. Now, in disorders of sexual development, we also have hermaphroditism. As I told you, the earlier term was hermaphroditism. Hermaphroditism, it can be true hermaphroditism or it can be pseudo-hermaphroditism. True hermaphroditism means that both ovaries and testes are present in the same individual, and that is what is called as ovotestes. The most common karyotype which is seen in ovotestes is 46XX. Right, so the most common karyotype for true hermaphroditism is 46XX. Pseudo-hermaphroditism means that karyotype, so they can be, in pseudo-hermaphroditism, they can be a male pseudo-hermaphroditism or a female pseudo-hermaphroditism. Male pseudo-hermaphroditism means that the karyotype is 46XY, but the external genitalia are either exactly female-like or they are somewhat female-like. Right? So if they are exactly female-like, then it is a female external genitalia. If it is somewhat female-like, for example, there is, penis is not there, but clitoris is enlarged, clitoromegaly is there, or if there is micropenis, or if there is labial fusion, all this is what comes under ambiguous genitalia. So if in males, testosterone is completely absent in intrauterine life. It is going to result in absolutely female looking external genitalia. But if in males testosterone is partially present, it is present, but it is not present in proper quantities to lead to the formation of penis. Right? So in that case, clitoris will get enlarged, but it will not form penis, and that is what is clitoromegaly, and that is what is ambiguous genitalia. Where by looking at the genitalia, you cannot say whether this genitalia belongs to male or female. That is what is ambiguous genitalia. Right? So if you have 46XY karyotype and there is ambiguous genitalia or exactly female looking genitalia, that is what is pseudohermaphroditism, male pseudohermaphroditism. Female pseudohermaphroditism means that the genotype is 46XX and the genitalia are male looking or they are ambiguous genitalia. Clear to all of you? Yes? Now understand this question. In this question, it is clearly given to you that there is 5-alpha reductase deficiency. If they are telling you that there is 5-alpha reductase deficiency, that means they are talking about 46XY karyotype, right? Now, in 46XY karyotype, right, the gonads will be testes, right? And testes are absolutely normal in this patient. Now, because testes are normal, so Wolffian duct will grow and so internal genitalia will be male internal genitalia. And because testes are normal, so Mullerian inhibiting substance will be formed and so Mullerian duct will regress, so there won't be any uterus. Right? Now, they are telling you that in this case, the problem is deficiency of 5-alpha reductase. And if there is a deficiency of 5-alpha reductase, so external genitalia will look exactly like females. And that is why this child will be born and brought up like a female. Right? So this child is going to be reared like a female. So please tell me if there is 46XY and there is external genitalia looking like female because 5-alpha reductase is absent. Right? What will this be? This will be a case of male pseudohermaphroditism. Male pseudohermaphroditism. Right? Now, you don't know anything about 5-alpha reductase deficiency, but you know all your concepts, right? So, I am telling you that over here, they will be brought up like a female, right? So, they will be taken as a female child. Now, what is going to happen at puberty? At puberty, again, testosterone is normally produced. The problem is 5-alpha reductase and the problem is dihydrotestosterone is not being formed. Because testosterone is being normally produced, this testosterone is not getting converted into dihydrotestosterone. It will get converted into estrogen. And that will lead to breast development in these individuals. Right? Because testosterone is normal, so they will also have pubic hair and axillary hair. And that is why your question is saying that a child presented with amenorrhea, she had normal genitalia, normal external genitalia looking like a female. She had normal breast development and her test revealed 5-alpha reductase deficiency. Obviously, if these children, they do not have any uterus, they will not menstruate, and because they were taken as a female child, because breast development is normal, parents expect them to menstruate, right? So that is why they are being brought to you as a case of primary amenorrhea. So in case of 5-alpha reductase deficiency, it means they are talking about 46XY karyotype. And whenever there is a 46XY karyotype with 5-alpha reductase deficiency, the external genitalia will definitely look like a female, and that is what is male pseudohermaphroditism, right? Clear to all of you? So true hermaphroditism, I've told you. Male pseudohermaphroditism, one of the causes you've seen just now is 5-alpha reductase deficiency. Other causes could be androgen insensitivity syndrome. Then it could be a Swires syndrome. In Swires syndrome, also you have male pseudohermaphroditism. Then it can be congenital adrenal hyperplasia, which is happening due to enzyme deficiencies starting with number 17. So enzyme deficiencies starting with number 17, they lead to male pseudohermaphroditism, whereas female pseudohermaphroditism, it is seen in congenital adrenal hyperplasia, which is due to 21 alpha hydroxylase deficiency, that's the most common enzyme, or 11 beta deficiency. Right? If there is congenital adrenal hyperplasia due to enzymes starting with number 3, it can either lead to male pseudohermaphroditism or it can lead to female pseudohermaphroditism. Right? Another very important cause of female pseudohermaphroditism, a differential diagnosis, is true hermaphroditism, because in true hermaphroditism, chromosome number is 46XX. So in female pseudohermaphroditism, you should always rule out true hermaphroditism also. Clear to all of you? Yes? Match the condition with appropriate hormone levels. Asherman syndrome, Sheehan syndrome, PCOS, and premature ovarian failure. So let's see. In Asherman syndrome, where is the defect? The defect is at the level of endometrium. Hypothalamus is absolutely normal. Pituitary is absolutely normal. Ovaries are absolutely normal. So if absolutely normal ovaries, so estrogen will be normal and right? And inhibin will be normal. So because estrogen, progesterone, inhibin, everything is normal. So LH and FSH, the negative feedback on them will be present and they will also be normal. So in case of Asherman syndrome, the problem is at the level of uterus. So you will see that all hormones are normal in Asherman syndrome because hypothalamus is normal, pituitary is normal, ovary is normal. Right? Whereas what happens in case of premature ovarian failure? In case of premature ovarian failure, the defect is at the level of ovary. Now, if defect is at the level of ovary, the levels of estrogen would be decreased and the levels of progesterone would be decreased, and hypothalamus and pituitary are normal. So hypothalamus and pituitary will be secreting LH and FSH. Now because estrogen is decreased, the negative feedback on FSH will be gone. So FSH will be high in premature ovarian failure. How much high? More than 40 international units. Because progesterone is decreased, so the negative feedback on LH is also gone. So LH is also increased. What happens to estrogen levels? Estrogen levels are decreased in premature ovarian failure. So in Asherman syndrome, everything is normal. In premature ovarian failure, LH and FSH are high. LH and FSH are high and estrogen is decreased. E2 is decreased, right? What happens in Sheehan syndrome? Sheehan syndrome is necrosis of the anterior pituitary gland. Now, if anterior pituitary gland is undergoing necrosis, all the hormones formed by the anterior pituitary will decrease. So FSH will decrease, LH will decrease, and obviously if FSH is decreasing, so estrogen is also going to decrease. So in case of Sheehan syndrome, all of them will be decreased, right? Now, what happens in case of PCOS? Now, in case of PCOS, there is excessive androgen productions from the ovary, right? Now, because there is excessive androgen production from the ovary, these androgens, they get converted into estrogen, but which estrogen? E1. So, in case of PCOS, it is E1 which is increased, right? E2 is not increased. Right? So, in case of PCOS, the levels of E1 are increased. E2 will remain normal in comparison to E1. Right? Now, because estrogen levels are normal, so the negative feedback on FSH will be normal. Right? So, the levels of FSH will be normal. Right? Now, all of you know that whenever the levels of estrogen are high, now in this case, even though it is E1 which is high, now this E1, what it is going to do, because the levels of E1 are high, E1 or E2, whenever the levels of estrogen are high, very high, they have a positive feedback on LH, right? So the levels of LH are going to increase in PCOS. Not only this, levels of LH will also increase because in PCOS there is an ovulation. No ovulation is happening. So if no ovulation is happening, so the levels of progesterone are decreased, and progesterone has a negative feedback on LH, and at low levels progesterone stimulates LH secretion. So at low levels progesterone has a positive feedback on LH. At high levels, progesterone has a negative feedback on LH. So in PCOS, the levels of progesterone are low, so it will have a positive feedback on LH, and that is why the levels of LH are high, right? So remember, in PCOS, when we talk about estrogen and specifically E2 levels are normal, right? But E1 levels are high. Because E2 levels are normal, so FSH levels are normal. But the levels of LH are high, and that is why we say LH is to FSH ratio is 2:1 or 3:1 in case of PCOS, right? So in PCOS, you will have LH high, FSH decreased, and E2 decreased. So either you can say estrogen is decreased and FSH is low normal, or you can say estrogen is normal and FSH is also normal, right? So this is what both the ways it can come. It can come that E2 is normal, then also it's fine, or they can say E2 is decreased, then also it's fine. They can say FSH is decreased, then also it's fine, or they can say it is low normal, then also it's fine. Right? The main thing is that over here, there will be a discrepancy between LH and FSH values. So whenever there is a discrepancy between LH and FSH values, then you have to think about PCOS, right? Okay, what happens in pregnancy? In pregnancy, progesterone will be secreted by the placenta and estrogen will be secreted. So in pregnancy, progesterone is also high and estrogen is also high. Because progesterone is high, it will have a negative feedback on LH, so levels of LH will decrease. And because estrogen is high, so the levels of FSH will decrease. So all this is physiology. And when we say that your basics should be strong, your concepts should be strong. That is why repeatedly in class, I keep, telling you that please understand the basics, because if your basics are strong, you can answer any question. All this is basic and we've done this in class. Coming to question number 15. Which of the following is the best measures for ovarian reserve? Again, we've done this in our videos, and that is anti-Mullerian hormone. What do you understand by ovarian reserve? Ovarian reserve is basically means the number of follicles which are present in the ovary. All of you know that as the age of a female progresses, the number of follicles, they keep on decreasing. Maximum number of follicles, they are seen in 5th month of intrauterine life, and they are 6 to 7 million. By the time a female takes birth, they drop down to 1 million, and by the time puberty happens, they drop down further to 4 lakhs. So as the age of a female increases, the follicles go on decreasing. In other words, the reserve of the ovary goes on decreasing. And now the question is, what is the main investigation which helps you, which is the best investigation which tells you about the ovarian reserve? The best investigation is anti-Mullerian hormone. Please remember that anti-Mullerian hormone in males is secreted by Sertoli cells. In females, anti-Mullerian hormone from puberty onwards, it is secreted by the granulosa cells of the preantral and the antral follicles. Preantral and antral follicles are those follicles whose size is between 2 to 6 millimeters, right? And their values are independent of gonadotropin. This test can be done on any day of the cycle, and that is why this is the best test. So as the number of follicles are going to decrease, the number of granulosa cells are going to decrease, and so the levels of anti-Mullerian hormone are going to decrease. Normal value of anti-Mullerian hormone is 2 to 6.8 nanograms per ml. In case of poor ovarian reserve, the value will be less than 1 nanogram per ml, right? And to be more specific, it will be less than 0.7. In patients of PCOS and in hyperstimulation syndrome, the levels of anti-Mullerian hormone are high. In PCOS, follicles do not mature. They never reach 20 millimeters in size. They remain small follicles, right? And there are very many small follicles, antral and preantral follicles in the ovary, and it is these antral and preantral follicles which secrete anti-Mullerian hormone. So in case of PCOS, the levels of anti-Mullerian hormone are high and they are more than 10 nanograms per ml. The other test which you can do for diagnosing ovarian reserve, or in other words, for diagnosing premature ovarian failure or premature ovarian insufficiency, premature menopause, all these are same terminologies, is serum FSH levels. The drawback with serum FSH is that it has to be done on day 3 of the cycle. Now, in case of FSH, please remember that as the number of follicles will decrease, the levels of estrogen will decrease. And so the negative feedback on FSH will be gone, and so the levels of FSH will be high. So if there is poor ovarian reserve, the levels of FSH will be high. And how much high? They will be more than 10 international units, right? So the normal values of FSH is less than 10 international units. In poor ovarian reserve, they become more than 10 international units. If there is, the value which is suggestive of premature ovarian insufficiency or premature ovarian failure is more than 20 international units. If levels are more than 40 international units, then 100% it is a confirmed case of premature menopause or premature ovarian insufficiency. Right? This value is same for menopause as well as for premature menopause. If you want to diagnose menopause, then also if FSH levels are more than 40 international units, we say the patient has attained menopause. And for premature menopause or premature ovarian failure also, it's the same value. Right? Then the third test which you can do is antral follicle count. Please remember certain concepts that in a reproductive age female, at any one point of time, it is 20 to 150 follicles which are growing in the ovary at one time, right? Only follicles which are more than 2 millimeters in size, they can be seen on TVS. Right? That means only antral follicles can be seen. And just now I told you the size of the antral follicles was between 2 to 6 millimeters. So on TVS, you can see only the antral follicles, and that is why we say antral follicle count. Antral follicle count is directly proportional to the number of primordial follicles. As the number of primordial follicles are going to decrease, the antral follicle count is also going to decrease. This test has got high specificity, but it has got low sensitivity, right? So there are 3 commonly used tests, in which the best one is anti-Mullerian hormone test. Apart from that, day 3 serum FSH levels and antral follicle count. Right? The tests which are not done, but which could have been done, but these days these are outdated, are clomiphene citrate challenge test, ovarian volume test, and estradiol level test. These 3 tests can also detect ovarian reserve, but they are outdated and they are not done. Next question, and that is a spotter. What is the probable diagnosis from the image shown? Now, in this image, now there is just 2 things which you have to understand. That either it can be an image, you can see uterus over here. So either it can be a uterocervical prolapse or it can be a uterine inversion. How are you going to differentiate between them? If you are seeing the external os, if external os is visible, it means it's a case of prolapse. In case of uterine inversion, it is the fundus of the uterus which will be visible. So external os will not be seen. So if external os is not seen, it is a case of uterine inversion, right? So this image over here, you are seeing the external os. That means it is a case of uterocervical prolapse, right? Why it is not cancer cervix? Because cancer cervix has got a very typical, appearance. It is a bleed. It is hemorrhagic cauliflower-like growth, right? So this is how cancer cervix appears. It's a hemorrhagic cauliflower-like growth, right? So this is not cancer cervix. Coming to question number 17. Which of the following is not used to treat PCOS? Again, a very, very simple question. All of you know that clomiphene citrate is used in the treatment of PCOS. Metformin is used in the treatment of PCOS. OCPs is used in the treatment of PCOS. Tamoxifen is not used in the treatment of PCOS. It is used for treating breast cancer, and it may lead to endometrial cancer, to adenomyosis, and to polyps in a patient, in a female patient, right? So all of you just remember one thing, and that is that tamoxifen therapy can lead to endometrial cancer. But please remember that tamoxifen therapy can also lead to adenomyosis, and it can also lead to polyps. Now, in PCOS, the treatment always depends upon the complaint with which the patient comes to you. So I'm going to tell you quickly what is the treatment plan in PCOS. If a patient comes to you with irregular cycles, then the first line drug or the drug of choice is oral combined pills. And whenever you are using oral combined pills in patients of PCOS, PCOS, you always have to use progesterone belonging to third or fourth generation, right? Because first and second generation progesterones have androgenic actions. So you cannot use them in patients of PCOS who already have hirsutism. You cannot use pills which have got side effects like androgenic side effects. Right? So whenever you are using OCPs or combined pills in a patient of PCOS, always use progesterone belonging to third or fourth generation, right? Then for insulin resistance. For insulin resistance, again, the drug of choice is metformin. The second drug of choice can be statins. Statins, they should be used only if a female doesn't desire pregnancy in future, whereas metformins can be used even if a female desires pregnancy in future. Then hirsutism. Whenever a female comes to you with hirsutism, again, the drug of choice is combined oral pills. That's the first line drug. Second line drug which you can use is anti-androgenic drugs like spironolactone, flutamide, finasteride, which become your third line drug. Second line is spironolactone. And please remember, whenever you are using anti-androgenic drugs like spironolactone, flutamide or finasteride, you have to prescribe OCPs to the patient. Why? Because these are the drugs which, just in case patient conceives, right, then they are anti-androgenic and they should not be used by a pregnant female. So whenever you are prescribing for treatment of hirsutism to a female, spironolactone, flutamide or finasteride, you should tell them to use contraception, right? Spironolactone, one very important thing which you have to remember is spironolactone, its side effect is orthostatic hypotension and it can lead to hyperkalemia. So it should be used very carefully in females who have renal failure. Rather, it should not be used in females who have renal failure. Third line drug which you can use for managing hirsutism is GnRH. And whenever you are using GnRH to control hirsutism, you are going to give continuous GnRH. When you are going to give continuous GnRH, it is going to decrease LH and FSH. And because it is going to decrease LH, all of you know that in females, LH acts on theca cells to produce androgen. So when you are giving continuous GnRH, the levels of LH will decrease and LH will not stimulate the theca cells to release androgens. And that is how it is used in treating hirsutism. One drug which is never used for managing hirsutism is danazol. And this question they can ask you, they can say that all of the following drugs are used in managing hirsutism except always the answer will be danazol. Why? Because the side effect of danazol is hirsutism, right? Then comes infertility, the most common complaint with which a PCOS patient is going to come to you. This infertility is anovulatory infertility, and the first line treatment for this anovulatory infertility, the first drug of choice is letrozole, right? It's an aromatase inhibitor and that's the drug of choice for treating infertility in PCOS patient. Second drug of choice is clomiphene citrate. Only if letrozole is not given, then you are going to mark the answer as clomiphene citrate. Now, the second line drugs for treating infertility in a PCOS patient is injection HMG, that is injection human menopausal gonadotropin, and you can also do a surgery, that is laparoscopic ovarian drilling. And the third line drug is GnRH. And when you are doing GnRH for ovulation induction, then you have to give pulsatile GnRH, right? So this is the management of PCOS. Please remember, always whenever a patient comes to you with PCOS, always, in all cases, you have to advise them lifestyle modifications and weight reduction. That is the thing which you have to advise to all PCOS patients. Question number 18. A 26-year-old female who has 2 kids through normal delivery presents with dull aching pain over the abdomen and irregular menses. Per vaginal examination revealed a mass felt through the posterior fornix. An ultrasound was done and a clear ovarian cyst of 5 into 5 centimeters was seen. What is the next best step? So over here, you have a reproductive age female who has got a clear ovarian cyst. Again, this is a question which I have taught to you in videos. Please remember that whenever a reproductive age female comes to you with an adnexal mass or an ovarian cyst, next step is never doing a CA125 level. CA125 levels should not be measured in reproductive age females. In these females, you just have to see the size of the ovarian cyst and its characteristic on ultrasound. If the cyst is appearing like a benign cyst. In other words, it's a unilocular cyst. There is no solid mass, no vegetation seen, septa is seen, but it is not a thick septa. Then there is no ascites, no enlarged lymph nodes, no matting of bowel loops. All this indicates that you are dealing with a benign mass or you are dealing with a benign cyst, right? But if any of these things are present, if any sign of malignancy is present, then I'm not going to think of anything else. If signs of malignancy are present on ultrasound, then irrespective of the size of the cyst, you have to remove it. So in the question, they are saying it's a clear ovarian cyst, right? And they haven't mentioned to you about any signs of malignancy. So because signs of malignancy are not present, now I have to concentrate on what size is given to me. Now, if the size of the cyst is between 3 to 5 centimeters, your next step is wait and watch. If it is between 5 to 7 centimeters, you should follow it up with ultrasound. And if it is more than 7 centimeters, you should do a surgery. Why I am doing a surgery? Not because if the size is more than 7 centimeters, there are increased chances of malignancy. I am doing surgery because if it is more than 7 centimeters, there are increased chances of torsion, right? So if it is less than 7 centimeters, I am not going to do surgery. If it is more than equal to 7 centimeters, then only I'm going to do a surgery when it is a benign cyst. So in this case, it is 5 centimeters. Because it is 5 centimeters, I am not going to do laparoscopy. No need for CT pelvis. I am not going to measure CA 125 levels. I'm going to follow up the patient. Now, while following up the patient, if the cyst doesn't resolve, right, and if cyst starts causing symptoms like pain or irregular periods, then you can prescribe oral combined pills for 3 to 6 cycles. Right? But please remember, if any sign of malignancy is present, if they would have said, instead of clear cyst, they would have said a solid ovarian mass. Now, if this would have been the terminology, then I would not have looked at the size, then I would have gone for surgery. Clear to all of you? But now suppose if your question comes that there is an adnexal mass in a postmenopausal female. In a postmenopausal female, always you have to measure CA 125 levels. So the next step becomes you have to measure CA 125 levels. If CA 125 levels are more than 35 international units, then that is suggestive of malignancy. And in that case, irrespective of the size, you have to do surgery. But if CA 125 levels are not raised, and if the size is less than 7 centimeters, again, you can follow up the patient with ultrasound and CA 125 levels. And if it is more than 7 centimeters, you have to do a surgery, right? So measurement of CA 125 levels have to be done in postmenopausal females, not in reproductive age females. Coming to question number 19, identify the condition shown in the image. Vulval carcinoma, Bartholin cyst, genital wart or vulval hematoma. Now what you are seeing over here is you are seeing a growth which is arising from labia majora. Right, so this growth which is arising from labia majora is going more towards vulval cancer. If it would have been a genital wart, this is the kind of image which you get in genital wart. You get verrucous growths, and sometimes these growths, they coalesce and they form a cauliflower-like growth. That is what is a genital wart. So this is not a genital wart. This is a growth which is arising from labia majora. If it is a Bartholin cyst, you get a cystic lesion which is arising from the posterior part of the introitus, right? It's in the between labia majora and labia minora. There will be a swelling which will be present more towards the posterior side. And if it is a vulval hematoma, you are going to get a tensed purplish colored swelling. So over here, this is none of these. This is a case of vulval carcinoma. Vulval cancer, the most common variety of vulval cancer is squamous cell carcinoma, and the most common site is labia majora, followed by clitoris and labia minora. Please remember, HPV is one of the risk factors for vulval cancers also. And the first lymph nodes in which the vulval cancer drains is superficial inguinal lymph node node, and if they ask you sentinel lymph node biopsy is helpful in which cancer, so the sentinel lymph node biopsy is most helpful in vulval cancer. Only if vulval cancer is not given, then you are going to go for cancer cervix. Question number 20. Symptoms seen in endometriosis are menorrhagia, dysmenorrhea, abnormal vaginal discharge, unexplained infertility. We've done this in class so many times that in endometriosis, the most common symptom which you get is pain, and in pain, the most common type of pain which you get is a secondary dysmenorrhea, followed by chronic pelvic pain, followed by dyspareunia, lower backache, and painful defecation. Now, when I say that there is secondary dysmenorrhea, it is congestive dysmenorrhea, and this pain is going to begin before menstruation. It will be present few days before menstruation. It could be that it is present a week before menstruation. It will be present at the time of menstruation, and this pain will not be relieved after menstruation. This pain, the secondary dysmenorrhea, is progressive in nature. It is new in onset. It is severe and is not relieved by the normal painkillers, right? So that is what is secondary dysmenorrhea. Please remember that pain in endometriosis, it correlates with the depth of the lesion, and unpigmented or non-pigmented lesions, they are more symptomatic than pigmented lesions. Now, that doesn't mean that in endometriosis, all patients are going to come to you with pain. There will be 25% patients who will be asymptomatic. The most common age group for endometriosis is 30 to 45 years. And please remember that the severity of endometriosis, it does not correlate. It does not correlate with the number and severity of symptoms. So the most common symptom is pain, and in pain, the most common variety of pain is secondary dysmenorrhea. You have to remember the sequence, that it's secondary dysmenorrhea followed by chronic pelvic pain, then dyspareunia, low back ache, and painful defecation. The second most common symptom is an adnexal mass, that is an endometrioma or chocolate cyst. Third most common symptom is infertility, and infertility in mild cases of mild and minimal cases of endometriosis is an unexplained infertility. In moderate and severe cases of endometriosis, it is due to tubal blockage, right? Then other symptoms which you can get is because these endometriotic implants, they are hormonally active. So bleeding may be present from these implants, also these endometriotic ectopic implants. So over here, patient can come to you with excessive bleeding, and so menorrhagia can also be a presentation of endometriosis, right? So in endometriosis, menorrhagia can be seen, dysmenorrhea will be seen, unexplained infertility will be seen, abnormal vaginal discharge is not seen. So over here, the answer is option B. Now, coming to the last question of the session, and that is, all of the following investigations are done to diagnose unicornuate uterus, and they had given you a set of investigations. Now, this question I have already discussed in NEET recall questions also. So the first investigation with which generally you suspect that a female has got Mullerian malformations or uterine malformations, that's a TVS most of the times, or instead of a TVS, it could be a saline infusion sonography also. But then ultrasound or TVS is not the investigation of choice. Rather, HSG is also not the investigation of choice, and I told you why that in the NEET recall session. The investigation of choice is 3D ultrasound, and the gold standard is MRI. Other gold standard, the previously gold standard was laparoscopy and hysteroscopy, but because they are invasive, so now they have been replaced by MRI. Please remember, X-ray and phalloscopy, they have no role in congenital malformations. Phalloscopy is an investigation in which you look at the interior of the fallopian tube with the help of an endoscope, right? So phalloscopy is not done for congenital malformations of the uterus. It is done to detect any cornual or distal block of the fallopian tube. Over here, laparoscopy and HSG, yes. HSG and X-ray, no. Phalloscopy and ultrasound, no. X-ray and laparoscopy, no. So X-ray and phalloscopy are not done in case to diagnose uterine malformations or unicornuate uterus, right? So with this, we come to an end of our discussion. And as you would have seen in Obs and Gynae, whether it was NEET PG or whether it was INI-CT, the questions were simple. But you know, what you had to do was you had to remember the basic concepts. And that is why always I keep stressing to you that please do not leave any topic. right? You should watch all the videos, and just in case you haven't watched any video, some topic is left, then I request all of you, whether you watched all the videos or whether some topic is left, for your upcoming NEET PG 2022, all of you should watch revision videos definitely. The entire Obs and Gynae, whatever updates I had to give you, whatever important points I had to tell you, I have given it to you with the help of the revision videos, and that is a must watch. Even if you have watched entire Marrow Edition 5 videos, if you are appearing for upcoming INI-CET exam, or if you are going to appear for your NEET PG 2022 exam, revision videos are a must, right? And if you want to contact me, you can contact me through my Instagram handle, Dr. Sakshi Arora, Obs and Gynae. Take care, keep practicing MCQs, and all the best.